Dr. Parveen, Associate Professor in Department of Infectious Diseases, Kasturba Medical College, Manipal. He is an infectious disease specialist with expertise in sepsis, critical care infections, and tropical disease infections. Dr. Praveen completed his DM in infectious disease from AIMS and has contributed extensively to research in areas such as sepsis, immunology, transplant-related infections, and emerging tropical illness. Sir, please.
Yeah, thank you.
So I'm still waiting the response for the pre-test. I have got only 4 responses till now. I request all of you to complete the pre-test. It's a time pre-test. It will get off by 8:45. So I request all of you to complete it as fast as possible now. I can know who has submitted, who has not submitted. So please let me know. I'm going to finish it fast. Okay? Thank you.
Yeah. So I'm Dr. Praveen Kumar Tirlangi. The whole CV, my area of interest is actually sepsis. So trying to understand sepsis, I kind of have to read everything else. So you'll understand that in the next 40-50 minutes. So how many of you are critical care physicians here? And how many of you are ID physicians? So how many of you are actually comfortable bedside when we are talking about immunology and immunological interventions bedside? Okay. So I'll be discussing sepsis and HLS. These are the few things which we keep we keep discussing bedside with most of the times no conclusions. And after that, we'll be focusing on immunological aspects. There's lot to read about immunology in sepsis, but we'll be focusing on 3 most important innate immune pathways, and I will take a lot of time to explain that. Because that is something which is very important, and that is where you can actually understand. All of you must be knowing now all the research we keep talking about transcriptomics, proteomics, and metabolomics. And the moment you hear about this terminology, you think that what is it? Like it is there for the last 20 years with no significant bedside application of this transcriptomics. So that you'll kind of become probably comfortable discussing these things bedside. After that, I'll give a break so that you can ask any questions if you have. Hopefully, I will be able to answer them. And then we are going to discuss a lot of nuanced cases where we have managed the last 1 year. But again, one person's nuance can be other person's anecdote. So I'm not claiming that this is a sanctum. This is all the truth which is existing there. But again, it is there for discussion because we are a small crowd. We can actually have a kind of an interactive session here, right? So we define sepsis as a infection causing immunodysregulation and that leading to end organ failure and eventually high mortality. So infection, probably we are trying to say that ID physicians are going to treat the infection. It's very important to understand that this is the first important step in sepsis. If you get it wrong, if you give a wrong antibiotic, whatever you do subsequently will not matter actually. In most of the trials, when you're looking into the ID trials, if you look at antibiotic trials, you'll actually see mortality benefit. But where in the critical care trials, you do whatever, there are only few, one or couple of trials where you have actually shown mortality benefit, like low tidal volume ventilation versus very high tidal volume ventilation, which is wrong to start with. But most of the times, you will not find any mortality difference. That's because you are intervening little late in the disease course. So the most important thing is choosing the right antibiotic. So the next couple of days, I think there are a lot of sessions in gram-negative bacteria, gram-positive bacteria, and fungus, where you'll be learning about how to manage the patients, how to choose the right antimicrobial for the patient. What about supportive care? In critical care ICU, I know all the critical care physicians will be dealing with airway, breathing, circulation, diet, electrolytes, fluids, infection, heart failure, liver functions, kidney failure, melena, neurological status, which is poor for the patient, delirium, oral hygiene, peptic ulcer prophylaxis, arrhythmias, bed sore, venous sites, thromboprophylaxis, and then you have a lot of catheters inside. Then you have sedation, analgesia, and neuromuscular blockade, and zeal of the patient, how the patient is feeling about it, psychological aspects. So these are all things which critical care physicians will be dealing with. So when I was given this topic, Dr. Jacob was like very clear, don't talk about fluids. We know how to manage fluids. So you talk about what is the ID perspective, but I think the whole conference is about ID. So we are going to discuss something in between, which is not discussed a lot and which can sometimes can change the prognosis of the patient. So when you are discussing sepsis, again, we have said that it is infection causing immunodysregulation that is leading to organ failure. But again, after immunodysregulation, there will be vascular issues, endothelial issues, and metabolic decompensation, which sepsis definition doesn't cover. However, we think that immunodysregulation is the first part after you control the source of infection and give right antimicrobials, right? This is a theoretical definition, but the problem here is you cannot say that in bedside define someone as sepsis because you are saying that there is immunodysregulation. So we have kind of operational definitions where we use delta SOFA, which has 6 different components, and increase in delta SOFA by more than 2 from the baseline is taken as sepsis with the evidence of infection. Now, this is a Western concept, like all the studies of validating so far from West. But we know in any medical issue in this part of the world, if you go and see, approximately 30% of medically sick patients will be from tropical fevers, like scrub malaria, enteric fever, leptospira, burkholderia, brucella, dengue, and KFD, sometimes chikungunya, right? And you all know that they have very specific clinical manifestations. For example, dengue will have thrombocytopenia. Doesn't mean that the patient is septic. So dengue patient with a low platelets, if you label him as sepsis, leptospira will have a little bit high bilirubin because the leptospira spirochete goes and dies in the bile canal actually. That won't harm the patient. Even if the bilirubin is 20, we know that it is going to recover. So in tropical sepsis, it is a problem because when you are in a LMICs, when you are making a policy, and if you are taking all this as a sepsis, you are falsely showing that the mortality is low. But this is not. We want to say that this is sepsis, right? So SOFA score, there is a recent update in SOFA 2, and again this also has this very same problem. So we have to understand that what the tropical sepsis is little different from what we are talking about a gram-negative sepsis in most of the trials. You can actually go through all these landmark trials in sepsis and ARDS and see what percent of these patients are actually tropical fevers. Either it is not represented or it will be a very minor portion. So when you are talking about management of ARDS, low tidal volume ventilation, recruitability, whether to give restrictive fluid strategy or liver fluid strategy, or how will you phenotype these patients, hyperinflammatory, hypoinflammatory, all this is not applicable. I'm not saying not applicable, but this is not the data from tropical ARDS and tropical sepsis. So we definitely need our own data. Probably we should come up with something like T SOFA score, the tropical SOFA score, and we should be able to show the prognosis is different with different scores. So any infection in the body, you can divide it into epithelial, endothelial, and macrophages. We'll come back to this. This is a little bit heavy slide, but tropical infections are endothelial diseases. All the patients with tropical disease will come with some amount of thrombocytopenia. Probably this is one of the soft clue where you see fever with thrombocytopenia, you'll start thinking about one of the tropical infections. So these are completely endothelial diseases. Whereas something like influenza is an epithelial disease. It infects the type 2 alveolar epithelial cells and causes ARDS, and hyaline membranes will be there. Just recollect that when did you last saw a case of scrub typhus or leptospira with ARDS, which never recovered, and it went into a fibrotic stage of lung and then required a ECMO for a long time or required a lung transplantation. You will not be able to recollect because these diseases are primarily endothelial diseases. So post ARDS fibrosis is probably, again this is my opinion, probably not something which we are worried about because alveolar epithelial cells are damaged late in this disease. So endothelial damage that will be followed by alveolar epithelial damage. Whereas some viral infections like influenza, which affect the type 2 pneumocytes, which are very important to regenerate the type 1 alveolar epithelial cells. If they are damaged, your patient is more likely to probably land up in a fibroproliferative and fibrotic stage of lung where you are not able to ventilate and not able to decannulate the patient or take him out of the ventilator. So when we are looking into a entry of a bug, so endothelium should not die. Basically, endothelium should not die. If it dies, then there is a problem. So endothelium will not have a lot of this inflammasome pathway where endothelium will land up in death. Inflammasome pathway is pyroptosis. We'll again discuss about it. And endothelium doesn't have a lot of antiviral immunity. It does have antiviral immunity, but it is not the expression of interferon 3/7 pathways which are associated with antiviral immunity is not very high in endothelium. So viral infections involving endothelium, it's a right milieu. So the endothelium cannot die, so virus can persist, and the antiviral immunity is not very strong. So some of the dengue, for example, dengue, it has a tropism for endothelium. Whereas epithelium has all these pathways, all the 3 pathways which we are going to discuss, and macrophages are very important. You can take an example of scrub typhus and spotted fever. Scrub typhus will involve both endothelium and macrophages. So that's why you hepatosplenomegaly, lymphadenopathy in scrub typhus. Whereas spotted fever is extremely dermatotrophic. You will not see hepatosplenomegaly, lymphadenopathy in spotted fever. It involves the superficial dermal layer. So when you see the patient, you will see that necrotic ulcers are there, and suddenly you'll think that probably it is gonococcal sepsis, meningococcal sepsis, or purpura fulminans. Patient won't be in shock, and it turned out to be spotted fever, which will respond to doxycycline very simply. What about the second part, HLH? So HLH is an extreme form of immunodysregulation we are talking about, where the macrophages will become so active, they will start eating your own cells, leading to anemia, thrombocytopenia, pancytopenia, basically with hepatosplenomegaly and persistent fevers and very high ferritin, right? So this is again the problem in HLHs. This is what you are thinking. So okay. So basically, you're saying that macrophages are becoming more and more active, and you see that CD8 T cells and NK cells are releasing a lot of interferon gamma, which is stimulating macrophages, and macrophages are eating other cells. So it is important to understand HLH can happen because of two reasons. One is a defective CD8 and NK T cells. So CD8 T cells and NK cells are also important to control the activated macrophages. So they will go and inhibit macrophages also. So by perforin and granzyme, which they secrete, and they will kill the macrophages which are in persistently active state. So if you have a condition where there is NK cell dysfunction and CD8 T cell dysfunction, patient can have macrophage proliferation and HLH. At the same time, if there is a condition where CD8 T cells or NK cells are proliferating, then also patient can have macrophages. This distinction is very important to understand, because this will decide how you are going to treat the patient, whether you are going to increase the function of CD8 NK cells, or you are going to give something which will like etoposide, which is going to kill everything which is coming onto the way. So this is the most important difference one should understand. For example, you see in a transplant patient, once you put a stem cells, in 3 months you are expecting NK cells, CD8 T cells to come, but you are saying that there is a period from 1 month to 3 months where macrophages are not very active, and NK cell, CD8 T cell dysfunction is there. In that period, if you have a viral infection, any viral infection can trigger HLH, right? So the problem with HLH again is the same. It is the biology which we are discussing, but you have a diagnostic criteria for HLH. You have this 5 diagnostic criteria. Most of you must be knowing, must be discussed in the bedside. And if it fits the 5 by 8, sometimes we use something called H score, which also gives the probability of it being HLH. And we all know that there are a lot of pitfalls. Like in bedside, you'll be discussing ferritin could be because of anything. Liver injury will cause high ferritinemia. Cytopenias are there in all the tropical fevers. NK cell function and interleukin, soluble interleukin 2 receptor, you'll not be able to do that. And even if you're able to do that, by the time report comes, if you're waiting for the report to come and not intervening, patient is going to die. Fibrinogen levels are very difficult to interpret. It's an acute phase reactant. So if it is high, low, you don't know how to analyze. Hemophagocytosis is something which we do a marrow and wait for a couple of days. It is basically that you'll get some time to say that you are evaluating the patient. But again, the sensitivity of hemophagocyte, demonstration of hemophagocytes in marrow is very low. Probably you have to take an average of 3 to 4 marrows to really show that there is a hemophagocytosis. So if you are going through this criteria, this is the bedside discussions we'll be having. Definitely in ICU rounds, there will be one person who will be saying everything is HLH, and there will be another person who is saying nothing is HLH. So these discussions will go on. A young resident will say, see, this is the criteria and it is fulfilling, and you are not treating the patient. Then you have a senior physician who says, yes, probably it is HLH. What to do? It is a secondary HLH. The treatment for HLH is treat the cause. Secondary HLH, treat the cause. Then the first year comes back. Okay, the patient has EBV. Now you tell me which antiviral are you going to give? Not all viruses, bacteria. Bacteria has antimicrobials. Not all the viruses you can treat by antiviral. So probably you have to modulate the immunity. Then kind of discussions. Okay, let us say that it is HLH, but we will not go with all the weapons we have. Let us give steroid and see for a couple of days. And if improves, it's okay. Then you are worried about how to taper the steroids, whether to taper it fast or not. And then how you don't know how to follow these patients when they are responding to the treatment, right? And then there comes a situation patient will deteriorate. Now you don't know whether to escalate on immunosuppression, or are you are also worried about a secondary infection. Probably patient is in the ICU, he got a fungal infection, is a secondary bacterial infection. Now you want to cover for everything, and when you give empirically polymyxin, patient is going to die. Polymyxin is an extremely toxic drug, which probably we'll be discussing a lot about it. But then you call rheumatologist and ID physician. Then rheumatologist will write again, treat the cause, and eventually you will come back to this situation where you want to give IVIG because you think that there is no harm. And IVIG, sometimes if you're not able to manage it well, 1 gram or 2 gram per kg dose in a day sometimes can affect the kidney, fluid overload. And this is the routine thing which is happening in most of the ICUs, right? So what we are trying to do today is to basically understand everything in very sub microscopic level. If you lose me for 5 minutes, you're gone. So you have to be very attentive in the next 15 minutes. I'm going to go very slow. And if you're not able to understand, you can actually stop me. If I'm crossing my time, I will cut down in my next presentation. Staphylococcus, everyone knows how to treat it. So we will understand sepsis and HLH at transcriptomic levels. And I will show you some of the clinical cases where this knowledge of these three innate immune pathways actually helped us to navigate through the situation. So we have discussed about infection, immunodysregulation. Again, in critical care, this is very important, right? If someone is having right ventricular failure, right ventricle, we say that critical care physician is equal to right ventricle, takes all the stress, but won't get any benefits. So always blamed. So this is how we manage sepsis. Besides antimicrobial immunodysregulation, the supportive care is very, very important. And great ICUs will have actually prolonged hospital stay of the patients, which is that is where your infection control will break. That is what we were discussing yesterday. So if you're not seeing any hospital acquired infection, you have to also ask the question, are you able to support the organs good enough? Like if patient is coming and dying in within a week, probably you will not see any hospital acquired infections in ICU. So we have discussed about infection, immunodysregulation, vascular decompensation, and supportive care. I think supportive care, Agra in February 2027, there is a critical care conference. You can always attend SIDSCon to discuss everything about infections. It is there in August in Gandhinagar, Gujarat. And today we are going to discuss something in between. So this is what I'm telling about Triaxis. And you can see that there is a YouTube channel which you can subscribe. It is my YouTube channel only, Triaxis with Tilangi, right? So the triaxis, this is what we are discussing about. So it has three important things. And in most of the cultural things, Hindu gods are three main gods, even in Greek mythology. So most important things in the world are three basically. And these are the three most important innate immune pathways. You must have heard about these pathways for sure, but most of the times we don't know what exactly it means. So let us start with IRF3 and IRF7 pathway. These are interferon pathways. These are very, very important for viral infections. So if you have a virus going into the cell and there are toll-like receptor 3, toll-like receptor 7, MDA5 receptor and RIG1 receptors. These are the receptors which will sense the viral RNA or DNA. Eventually, they will lead to stimulation of IRF3 and IRF7 pathways, which will lead to secretion of interferons. We all know that interferons are very important in antiviral immunity, right? So there are two important interferon alpha, interferon beta. Interferon beta is local interferon. Interferon alpha is a systemic interferon. And these interferon will code for something called interferon signaling gene, which will kill the virus. So basically virus is coming, your interferon 3/7 system is able to see it and it is killing the virus. It is very important for antiviral immunity, but it can be detrimental for bacterial infections. Okay. And it can also be a little bit helpful in bacterial infection that we will see. Let us go to the other pathway, which is called inflammasome pathway. There are a lot of inflammasomes in the body. NLRP3 is the most important inflammasome. Basically, if the body is not able to clear the intracellular bacteria, it will stimulate eventually inflammasome pathway where cell will die. And cell will release something called interleukin 1 beta, which is the most important pyrogen. So if you are seeing a patient with high spiking fever, you are actually seeing very high levels of interleukin 1 beta. Okay. Along with interleukin 1 beta, there is interleukin 18, which is very, very important to stimulate macrophages. So when we are saying HLH, macrophages are active, eating everything. Interleukin 18 is stimulating NK cells and CD8 T cells to produce a lot of interferon gamma, which is leading to HLH. So this interleukin 18 is very important. So if you have very high interleukin 18, but you are not able to see a lot of interferon gamma, that means your T cells are paralyzed. That is how we interpret, right? So you cannot do a bedside interpretation of interleukin 18. But then comes something called NF-kappa beta pathway. It is important even in oncology, in rheumatology, in infectious diseases as well. Most of the infections, especially gram negatives, the endotoxin is a very strong stimulator of NF-kappa beta, which will lead to eventual secretion of TNF alpha. Now, TNF alpha will cause vasoplegia and capillary leak. IL-6 will cause high CRP prothrombotic state, inflammation. And then you have IL-8. IL-8 will cause neutrophilic recruitment. That's what you see in pneumonia, IL-8, neutrophilic recruitment there. Then IL-12 is again important in the macrophage and T cell pathways. So there are three important pathways. Of the three, the inflammasome pathway and NF-kappa beta pathway are propagating each other. So if your NF-kappa beta is very active, your inflammasome will be more active, and that will lead to more stimulation of NF-kappa. This is a loop. And interferon pathway, IRF3 pathway, is a inhibitor of inflammasome pathway. So it is kind of stops it. It is very important to understand this because high levels of endotoxin will stimulate NF-kappa beta pathway predominantly. Low level of endotoxin will stimulate interferon pathway predominantly. So if you have a patient with gram-negative sepsis, patient is having high CRP, vasopressor, you are treated. After some days, the endotoxin levels will come down. And that is the time the endotoxin is preferentially activating interferon pathway, leading to lymphopenia, cytopenias. This is the state of immunoparalysis, where the patient is going to have reactivation of CME within the hospital, can develop candida, can develop mold infections or other hospital-acquired infections. And if the patient goes into shock again here, are you going to use steroids again? Because patient is in shock, septic shock, dose of steroids can be more harmful than beneficial, right? Let us take an example of bats. Okay. Now, bats are only flying mammals. If you start flying, you will die because there will be a lot of oxidative stress in the body. So your inflammasome pathway will get activated and it will lead to a lot of secretion of IL-1 beta, IL-18, and humans are going to die. But bats are the only mammals which can fly. So then they will not have a NLRP3. The signaling of NLRP3 in bats are dampened completely. Then again, we have interferon signaling, which is antiviral signaling intermittently. Whenever we are exposed, this is activated. In bats, it is constitutively activated. So let us assume they have bat which constant interferon activation, but not very high levels. So it can control the virus, but it cannot kill the virus. And then it is, if the virus is not killed, ideally the inflammasome pathway should get activated and cells should die and the bat should die. But the inflammasome pathway is dampened. That is the reason exactly why bats can carry multiple viruses inside them without dying, because it is the normal mechanism, because they have to fly, so NLRP has to be dampened. I hope this example will help you. So this is what we are discussing in gross. NF-kappa beta pathway lead to high TNF alpha, IL-6. Inflammasome pathway will lead to high interleukin 1 beta and eventually HLH like phenotype, and IRF3/7 pathway which leads to interferon alpha and beta. So now when we discussing HLH, we are discussing mostly about inflammasome pathway, right? Interferon gamma secretion, macrophage activation. But in reality, interferon gamma pathway, like inflammasome pathway, will come along with NF-kappa beta pathway. So HLH with high CRP is different. HLH with low CRP is different. HLH with low CRP, you are not worried. HLH with high CRP, the prognosis is going to be poor. So even if you forget everything till now, whatever we have discussed, if it's so complicated, let us simplify it further. TNF alpha causes vasoplasia, capillary leak. So I have a patient with shock, you are seeing edema, capillary leak, and vasoplasia, not responding to NORAD. You have increased the NORAD, heart rate increased, but diastolic BP didn't. That indicates it's not going to respond to NORAD, which we call it as diastolic shock index. That is TNF alpha. Okay. You have a patient with high CRP, high fibrinogen, looking thrombotic. You got a thromboelastography. You are seeing a fibrinolytic shutdown. There is lysis 30 is 0. That is IL-6. IL-6 and TNF alpha most of the times come together. So if you are seeing a gram negative, because NF-kappa beta pathway lead to activation of both. So if you are seeing a gram negative pathogen with vasoplasia, capillary leak, thrombosis, and high fibrinogen, basically you are seeing high TNF alpha, IL-6 bedside. Okay. What about interferon gamma? Interferon gamma is interesting because interferon gamma also increases the, because inflammasome pathway and NF-kappa beta pathway are in loop. So it also increases the secretion of TNF alpha and IL-6. But interestingly, interferon gamma inhibits the CRP production by IL-6. So if you're seeing a patient with a high interferon gamma signal, the CRP is actually, you can see the CRP in a transcriptomics. When you're looking for CRP RNA, RNA, you can see that the RNA is expressed, but CRP won't be produced. So interferon gamma is a very interesting signature that it will cause low CRP. Patient will have hepatitis and thrombocytopenia. So hepatitis, thrombocytopenia with low CRP. It is a very classical signature of interferon gamma pathway, which we If you read about sepsis phenotypes, you must be discussing about gamma phenotype, alpha, beta, gamma. That gamma phenotype is exactly this hepatitis with thrombocytopenia, DIC like picture. Okay. So bedside, you can do that. So you know now, fever is IL-1 beta, high CRP is IL-6, high CRP with prothrombosis is IL-6, TN alpha will be DIC like picture, and it will have vasoplasia and shock. Interleukin 8, we discuss it because it is very important. There are some bacteria which will cause, where the decreased IL-8 will cause more septic kind of picture, like melioidosis. If you don't have good IL-8 signaling, you will not be able to form abscesses. So it will disseminate to different places. So I hope this is little bit clear. So now we will go to some of the studies of what people have done since 1990s. This is not something new. You must have read a lot of studies which are all negative, but all these negative studies are there to teach us something. So let us go to some of the studies. We discussed about endotoxin level. Very high endotoxin causes NF kappa beta stimulation. Low level will cause interferon alpha beta stimulation. Both are bad. So both are bad. So endotoxin has a Goldilocks zone. This is the exact zone where removal of endotoxin will work. So initially, when the people have gram-negative sepsis, the endotoxin is causing all this. Let us remove the endotoxin from the circulation. So let a lot of extracorporeal studies are there. Toromyxin beads, some of you must have used. So there are a lot of studies initially with initial study U first, which has stopped in between, showed some benefit. Then that was followed by a abdominal sepsis trial called Abdomix, which was negative. Then you got a Euphrates trial, which is negative. But in that trial, you looked into the range of endotoxin where it might work. It was found to be 0.6 to 0.9 there. And recently, there is a trial called TIGRIS trial, where they have recruited patients with only endotoxin activity of 0.6 to 0.9 and used a toromyxin beads, which is shown to have mortality benefit. So this is very important, not the trial, because they have screened for like 12,000 patients. Of that, 120, 150 patients are recruited, because it's not externally applicable. But this is very important to understand the Goldilocks zone of endotoxin, which is also important in your routine practice when you're treating a gram-negative infection. Once you think that the endotoxin levels are decreased, you should stop steroids. So should not prolong steroids to taper it for 2 weeks, 3 weeks. Try to come off steroids once the patient is little stabilized. So as we discussed till now, it is not very difficult to understand that if it is a hyperinflammatory sepsis, probably you want to give a TNF alpha blocker or IL-6 blocker for the patient, and is a hypoinflammatory phenotype, then probably you want to give something which stimulates the immunity, right? So people have done a lot of trials to block TNF alpha. So the first trial was in 1996, which has shown harm. That was followed by Noracept 1, Noracept 2, and Intercept trials. No benefit with TNF alpha inhibitors. Then Ramses trial, there is no benefit. Eventually in 2004, there is a trial called Monarch trial. Again, overall there is no benefit, but this is the only trial where they try to recruit the patient with hyperinflammatory phenotype by looking into the IL-6. But you can see that there is some signal in the patients. There is a 3 to 4% mortality benefit, which you cannot say that very significant. At the same time, you cannot neglect it also. So we understood after that TNF alpha inhibitor, obviously TNF alpha, like we are trying to give one immuno suppression and expecting the patient to improve, but there is a lot of story which will happen after that, right? So the interest on TNF alpha is gone after 2004 because all the trials were negative, but they're actually not completely negative. There is something to learn from these trials also. How about anakinra? Anakinra is interleukin 1 beta inhibitor. Again, if you inhibit the inflammasome pathway, it is eventually going to affect the NF kappa beta pathway also. So it is good, right? You give a single shot drug which will act in both the pathways. And you must have known that in Bangalore recently there is a trial published for anakinra and dengue, and it's a single arm trial. We cannot make any big conclusions, but the dengue patients who are very severe, they improved with anakinra. So interleukin 1 beta is a very interesting concept, but the first trial was negative. So subsequently, Shakuri et al. And their group, they have done a subset analysis of this trial, and they identified this phenotype called hepatitis with thrombocytopenia phenotype, which we also call as gamma phenotype, which indicates that there is an enrichment of interferon gamma and inflammasome activation. In this phenotype, there is a very significant mortality benefit. But this is again a subgroup analysis. In India, anakinra is not available and it is very costly. Most of the people who use anakinra, they use in pediatric group because the body weight will be very less. The amount of dose required anakinra will be less. I have no experience using anakinra. So there is a recent study again in Lancet published, which is a phase 2 study where they again biomarker guided anakinra they tried, and it is shown to have very significant benefit at least in a phase 2 trial. We cannot phase 3 is yet to be done, but anakinra is coming back into the sepsis immunomodulation spectrum. What about TOSI? We have used TOSI so much in COVID. It makes all sense to, like, you see the patient with high CRP, probably you can give a tocilizumab and let the ID physicians decide about what is going to happen next, whether it is gut is going to perforate or patient is going to have candidemia or complicated staphylococcal infection. But you can actually give TOSI, and that crisis of initial vasoplegia, probably you can get over that. That makes a lot of sense to give tocilizumab. Has anyone done that? There are a lot of studies till now that IL-6 associated sepsis and high IL-6 associated mortality, and we bedside we know that this is the phenotype. So there is logically there is all the reason why we should be bringing IL-6 blocker. May not be TOSI. TOSI has a very long half-life. So when you're managing sepsis, probably you want to have IL-6 blockade for shorter so that you can kind of avoid the side effects at the same time, go through that period of vasoplasia where you are increasing NORAD. This is not uncommon. You start NORAD, and the moment after 1 hour you see that diastolic BP is not picking up, but the heart rate is going high. The patient is not going to respond to the pressors you are going. Whatever strategy you are using, that's not going into the right direction. You have to alter the strategy. So makes a lot of sense. So this is the group again. All the papers of tocilizumab came from the single group. These are small studies, case series, and small retrospective studies. But this is interesting because they haven't used toci in normal patients. They have used it in febrile neutropenia patients. So can you imagine giving toci for a patient with febrile neutropenia? Now we are discussing a lot because most of the febrile neutropenias are actually not infections. Hardly less than 50% of the cases you will get, even if you do a NGS. So most of these febrile neutropenia is actually because of tissue damage, release of a lot of damage associated molecular patterns stimulating NF kappa beta and shock. So in febrile neutropenia patients, they are used, and many of these patients are actually, they had a drug resistant infections existing along with febrile neutropenia. So it's not like they are completely sterile also. They have done 3 case series. In all 3 series with the comparative arm, if you see, there is a significant mortality benefit. Am I trying to say that give tocilizumab for all the patients with refractory septic shock? No. But is there any future for IL-6 blockade in sepsis? I think yes, especially if you can make a bispecific antibody with albumin, IL-6 and TNF-alpha, which is short acting. That is going to probably change. And there are a lot of animal studies already happening, which is showing a lot of beneficial, at least in animal studies, it's showing a good benefit. So what I'm trying to say is, in a critical care ICU, where patient is having severe vasoplesic shock, and your pressors are not working, and then you have ruled out anything which like, if patient is not well fluid resuscitated and there is a dynamic obstruction at heart, you increase the NORAD, patient is going to die anyway. What about capillary refilling time? And after Andromeda shock trial, this is very interesting, right? You see the capillary refilling time, assess why there is a microcirculatory dysfunction. Let us assume you have kind of ruled out all the mistakes you can do when you are escalating NORAD, and then you think that the patient is not responding and is going to die. Most of us actually know when we are managing the patient, at least a day before, that this patient is not going to make it because the direction is not wrong. Patient is not going into the right direction. Most of the times we do know, but we tend to limit ourselves to so-called evidence-based medicine, which we understand wrongly from the first step. Evidence-based medicine is not about quoting 4 trials, Bedside, and quoting 4 guidelines. It's about, one is evidence, what is there, a good quality evidence. Second is, what is the experience of the treating physician. Third is what the patient wants. So if you are able to talk to the patient, explain that this is what we are thinking, and if they are okay with it, I think as a strategy, where you want to save the patient who is anyway going to die, probably it should be tried in our ICUs also. This is my personal opinion again. uh, this is what we have discussed. What about hypoinflammatory phenotype? Now it is very easy to say that this is hyperinflammatory sepsis. It's the hypoinflammatory. Hypoinflammatory sepsis you'll be seeing in your ICUs with a lot of lymphopenia. So if you see a peripheral blood smear or CBC, you see lymphopenia is there. So these patients are more likely to again die because of secondary infection. But in reality, it doesn't happen like that. You will actually see a patient with severe vasoplegia. Simultaneously, patient will be having lymphopenia. So patient will be a state of hyperinflammatory and hypoinflammatory sepsis. Hyperinflammatory in innate immune pathways, hypoinflammatory in adaptive immune arm. So this is usually this is where we are getting it completely wrong. We think that it is a hyperinflammatory. So there is one trial by Richard Hodgkiss by using checkpoint inhibitors, nivolumab in sepsis, the phase 1 trial, not shown to be harmful. Obviously, in phase 1 trial, you are looking at safety, and the same group has used IL-7, which is a stimulant of lymphocytes. So IL-7, and in that particular trial with IL-7, then they have shown that patients with this phenotype of severe lymphopenia, they benefit. Even in animal models, in humans, one trial is there. But in reality, what is happening is you see a patient who has both. So probably you have to use strategy to get through that hyperinflammatory phase, because hemodynamics are the most important thing. Once you are not able to manage hemodynamics, there is a kidney failure, refractory shock, we are not able to do CRRT also. And once that, you have to reassess whether the patient is going into a phase of hypoinflammation like lymphopenia. Probably something like IL-7 will come. When we are reading about cytokines, we always think about IL-10 being a anti-inflammatory cytokine, but you can get it completely wrong, because IL-10 causes apoptosis of CD8 and NK cells, which can lead to unregulated activation of macrophages. So in HLH, actually what you will see is very high IL-10. So that doesn't mean that the patient is in a hyperinflammatory state, right? This also happens especially with EBV. So most of the HLH, when you're deciding, you always see some EBV reactivation or probably HLH because of EBV. But most of the time, EBV is not a silent bystander. That is what we have to understand. EBV increases the expression of something called PD-1 and PDL1 on the surface of the cells. They are like breaks of immunity. So your CD8 NK cells are again not able to act and kill the macrophages or other infected cells, leading to HLH. So EBV actually increases the PD-1L1. So in EBV associated HLH, you can actually give something which is an immunostimulant. So there is a patient with HLH, and logically, if you give in PD-1 blocker, patient would die, but patient will improve because you are blocking, you are reactivating the CD8 T cells, which are supposed to kill the viral infected cells, right? So in chronic active EBV infections, there is a literature, and the response rate of chronic active EBV HL is around 75 to 80% in these patients. Many of the patients were responded in 2 to 3 cycles. Median they have taken 6 to 10 cycles, and it is again a case report kind of data. We cannot say how many cycles the patient should get, but this is a very attractive strategy if the patient is not able to undergo transplantation, right? So I will take a break here, and if there are any questions, I'll be happy to take them. Till now, anything that you are not able to understand? If nothing is there, I will take. Sir. Sir. Yeah, sir. So, uh, so basically, sir, the pattern recognizing receptors for bacteria and fungi are different. You will be looking at dectin-1 receptors, or but eventually they will also eventually stimulate the NF-kappa beta pathway. So if you are looking at Candida, Candida is going to eventually go and stimulate the NF-kappa beta pathway. Now it depends upon the virulence of Candida. The Candida glabrata and auris are different, where you keep growing Candida auris and you see that patient is otherwise hemodynamically stable. And Candida albicans and tropicalis are quite different, especially tropicalis it looks more virulent. The pathways are different through which the NF-kappa beta pathway is getting stimulated, but eventually everything goes through NF-kappa beta pathway or inflammasome pathway or IRF37 pathway. The Candida sepsis is mostly NF-kappa beta driven. Yeah. 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 So
in case of this bacteria, we get this focal sequence going on.
Very high profile, yes.
But CRP is rising both in this scenario and that.
Great question.
Difference, why that difference is there?
This is the most important question which we have to understand. The NF-kappa beta pathway can produce TNF alpha, can produce IL-6. CRP is predominantly IL-6 driven. Procalcitonin is both IL-6 and TNF alpha, but predominantly it is TNF alpha driven. Now, when we are stimulating NF-kappa beta pathways in different areas, for example, there is an endothelial infection. In endothelial infection, the NF-kappa beta pathway is deviated towards CRP production, not TNF alpha production. Even in topical fevers, you will not see a lot of procalcitonin. You will see a CRP rise. Similarly, based on which side it is deviated, whether towards TNF alpha or IL-6, you will see a discordance between CRP and procalcitonin. This is very interesting because people have looked into the ratios of procalcitonin and CRP rather than looking at CRP and procal alone. So most likely, I have to look into it, but most likely the Candida infections, we are seeing more of a NF-kappa beta pathway, which is deviated towards IL-6 production rather than TNF alpha production, sir. This is how we actually follow a patient with HLH. There is a patient with HLH, you have given steroids. Now patient is improving. If ferritin is coming down, the interferon gamma pathway is coming down. But then if you see increase in CRP, CRP could be cause damage associated molecular patterns. So in there is some tissue damage, NF-kappa beta pathway is deviated to CRP, not TNF alpha. So if you are seeing CRP, you are seeing a sterile inflammation coming up, or probably candida, or probably a gram positive infection without increase in procal. But then you are seeing a trend where patient, you are treating steroids and then the CRP is gone up. Now procal is also gone up. Then you are looking at some secondary infection. So when you are treating HLH, it's very easy to start. It's like a riding a lion. It's very easy to climb, but you cannot get down from it. So you started the patient on etoposide, cytopenias. Ferritin is coming down, CRP is low, procal is low, you are going right. Ferritin is going high, increase immunosuppression. But ferritin is going high along with procalcitonin, you have a problem. Ferritin is going high along with CRP, then also you have a problem. So you have to search for other sources at that point of time. Thank you, sir. So I will take you through, how much time do I have, sir? I have some time, like
10 minutes.
10 minutes. 10 minutes, I will take you through some of the very interesting cases. So we discussed about interferon gamma pathway causing hepatitis with thrombocytopenia. So I was working in KMC Manipal for the last few years, and I'm not at all interested in tropical fevers. When I came here, I was like, what is the deal with tropical fevers? You give us ceftriaxone and doxy, and most of the times that is the antimicrobial treatment, and why you need ID for that. So I was not very interested. I was more want to understand sepsis. Probably I wanted to understand how immunosuppressed patients they behave. But then we saw this curious case of KFD. Every time KFD is Casnur forest disease. Probably you will also be seeing this patient. Every time patient comes, you will see very severe hepatitis, thrombocytopenia. CRP will be in single digit, probably not even single digit, something like 0.6. So this is the patient where ferritin is more than 1 lakh, and ferritin is more than 1 lakh, you'll be like, what is HLH? Fever, ferritin, heptosplenomegaly. Is it HLH? Then you look at CRP. CRP is getting, this is where we understood that actually interferon gamma inhibits the production of CRP. So this is a pure interferon gamma type of phenotype. So we didn't give anything, steroids, nothing. Patient went home, discharged. We got a serial transcriptomus for this patient. Every third day we are looking into it, and it was like amazing. It's a single patient, but KFD is hijacking the NF-kappa beta. NF-kappa beta is completely silenced in KFD, and it is also hijacking little bit all the viral infections. They will hijack the interferon pathway. That's the reason why they are able to produce a clinical disease. Now viral clearance is completely dependent on inflammasome pathway. So eventually interferon gamma is trying to clear this infection. So it might look like HLH, but if you block that interferon gamma, there is no way you're going to clear the KFD as well. Unless it is causing end organ damage, there is a problem, you should not touch it. This is what we learned. But then we also tried to correlate it with metabolomics. So what does interferon gamma does to tryptophan? So interferon gamma will increase the metabolism of tryptophan into something called quinolinic acid, which is neurotoxic. So then we are like, it's no brainer that KFD comes in two phases. First phase, there is a very significant interferon gamma pathway, and there is a leak of blood-brain barrier, and lot of quinolinic acid is produced. That will go to the brain, and that will stimulate the already primed microglial cells, leading to neurological symptoms, which are which will stop them on themselves. But again, the areas which are very concentrated with microglial cells are affected, something like cereballitis. So that's how we are trying to understand post KFD cereballitis. In between, we saw a pattern. We went back. So all the patients who died of KFD, you feel that it is a Casnur forest disease, a hemorrhagic fever, right? But then when we looked into the data, 50% of the patients who died, they died because of the refractory status, which couldn't get controlled. So what do you do in refractory status? You start the patient on benzodiazepines. Aggressive physicians will intubate first so that you can take complete control. Start the midas infusion, propofol. In between, you load them with levera, phenytoin, valproate. This is every time they are doing it, seizures are not getting control and patients are dying. So this, we propose that this is because of NMDA activation mediated by quinolinic acid. Same mechanism how cefepime causes encephalopathy. It increases the quinolinic acid in the brain. So NMDA activation is the cause of seizure. So no matter how much GABA you are going to block with benzodiazepines, propofol, it's not going to respond. So next patient when we came with refractory status epilepticus, we pushed the steroids, label it as NORSE, new onset refractory status epilepticus, push the steroids for 3 days, and we started upfront ketamine infusion. And this is the first patient we saw that the KFD with refractory status gone home with a completely normal neurological status. So this, based on this understanding, we are able to manage this patient, right? What about EBV? We are discussing about EBV. EBV drives T cell exhaustion. Now we have a patient with HIV with hepatitis, and the biopsy was done. It was a granulomatous hepatitis. AFB gene expert was negative, but granulomatous hepatitis in HIV patient, you are not able to find any cause. So started on ATT from outside, received ATT. In between, she was okay. Then she developed hepatitis, labeled as ATT-induced hepatitis, where we got a consult to modify the ATT. We have modified the ATT initially, but then we understood that it is probably not TB. But it's very difficult to say in a retro patient it is not TB. But when we evaluated, we found that there is a EBV viral load was very high. Now EBV viral load is very difficult to interpret again. So eventually, patient required 3 biopsies in some time. She was labeled as HLH. We started the patient on steroids and etoposide. The patient is responding to etoposide, but the moment you take the etoposide off, it is coming back. So patient had 3-4 admissions. After we trying to take off the patient off etoposide, the HLH was coming back. So basically, there is a EBV infected clone which we are not able to clear it. So the moment you take off etoposide will kill everything. The moment you take off, that EBV clone is causing HLH again and again. So at this point of time, we thought we will give checkpoint inhibitors. So we gave very low dose of nivolumab, and we gave it for 6 cycles now. Yesterday she got a PET-CT. PET-CT is completely clean. So we managed a chronic active EBV in a retropositive patient using checkpoint inhibitors. There are a lot of case reports, but not in HIV patients, because usually our assumption is checkpoint inhibitors will only work if there is some immunity left. If it is very lymphopenic, what are you blocking? That is the question. In fact, most of the EBV associated lymphomas, they respond to checkpoint inhibitors for the same reason. So EBV is not just a bystander. It makes a condition where patients will go into eventually HLH. This is again a HIV patient who got admitted with intensive care unit, and he was diagnosed to have tuberculosis. Tuberculosis induced hepatitis, and then HLH. We gave 1 dose of it. So again, when we are giving etoposide, you don't have to follow that twice weekly. You can always give a dose, go through that crisis. If the patient is doing okay, you manage on the steroids, avoid the second dose, especially when the patient is becoming extremely cytopenic. Second thing is etoposide is metabolized by liver. So most of the HLH patients will have liver involvement. So liver involvement is not a contraindication to give etoposide. Probably you can dose modify. Now this patient was having HLH, received a steroid, but he became steroid dependent. No matter, every time we are trying to taper it off, it is coming back. Taper it off, it is coming back. So then in HIV patient, there will be a lot of other etiologies which you want to evaluate. You could have missed some other bug which is coming back again and again. This story is going on for months. Eventually, we got a PET-CT. In PET-CT, we found that there is a significant uptake in spleen, nowhere else. So now we are worried, like, is it TB we are treating, or is it some other thing, anocardia, CMV, or lymphoma sitting in the spleen? And what is the way to confirm it? So we took out the spleen. This is how it is. It's like TB studded, right? So that's the reason why there is the active TB which you are not able to control. So it is driving HLH. You are giving steroids, it is getting cooled down a little bit, but you are not treating the TB. TB is the cause for HLH, and we are not able to treat that. And the patient is, and there was a lot of confusion because the other sides it responded. Spleen worked like a sanctuary site. Probably the drug penetration to the spleen was not good. But eventually we thought probably this is the problem with treatment of TB. We don't have drug levels in our place. We have tried to do drug levels in this patient long before, but by the time sample went to Hinduza, it was already bad. So we are having that difficulty in coordinating. Eventually we got TB drug levels, rifampicin and ethambutol are like very low. So this patient, we increased the dose of rifampicin ethambutol, rechecked the drug levels, and after that, we were able to slowly taper off the steroids. So spleen acted like a sanctuary site. At the same time, drug levels were the problem in this. I will take 5 more minutes. So this is again one more patient, the classical leptospira, right? High bilirubin. Leptospira is confirmed beyond doubt. Now this patient had diffuse ulnar hemorrhage, which we'll be discussing in the next session. Got steroids. We don't give pulse steroids. We avoid because most of these patients with Acinetobacter steroids, the polymyxin steroids with neuromuscular blockade, tracheostomy is confirmed. So we give 40 mg BD. Patient improved actually. The CRP was coming down. The oxygenation improved. Fevers came down, but the oxygenation gets stuck somewhere. So he was having a persistent CO2 retention, which we are not able to understand why. So if you have a CO2 retention, you have all the causes which you want to look out. After that, you want to look the gradient of EtCO2 with PaCO2. If gradient is high, that indicates dead space. So there is a poor perfusion to some segment of pulmonary vessels. So the reason for that in ICU could be many. You might be giving very high PEEP, which is distending and compressing onto the pulmonary capillaries. It could be large pulmonary thromboembolism. We got a echo, no RERV strain. Cardiologist was not convinced. We got a CTP, it was clean. So we hypothesize probably it is microthrombosis. Cardiologist said nothing doing, platelets are low. You just wait. The problem is the patient is having the CO2 retention with improvement in oxygenation, and we were not able to manage, and we kind of ruled out everything else except microthrombosis. So I was like, shall we give a low dose of thrombolytics? That was very dangerous. So we kind of discussed and came in between, like bargain and said we'll give a therapeutic dose of anticoagulation. Magically, next 48 hours, patient got extubated. The oxygenation has improved. Now it is very difficult to say that you have given anticoagulation and existing clot got fibrinolyzed. That is true, but body's mechanism in such a way that when the thrombus is getting formed, your fibrinolytic pathways will be shut down. So if you stop forming new thrombus, the fibrinolytic pathways in your body will get activated. That's the reason why in pulmonary thromboembolism, where you're not thrombolizing, the anticoagulation also works very well. In between, again in ICU initially this patient was prone because they wanted to see whether the ventilation is improving after proning. It didn't improve, so they supined again. Then just before after we gave anticoagulation, they proned again. Patient improved. Now there is a clinically significant bias that is the anticoagulation effect, or is it because of the proning better way? So critical care physician says it is proning. I increase the anticoagulation. Why I should not take the credit? So I was like, it is because of anticoagulation. But we are like, okay, it could be anything. But then this discussion came to the wards. From the ICU, got discharged and wards. So now there is a situation where my ego is getting hurt because everyone is saying because of the proning patient improved. Then we are like, he should have improved in the first place. Why he didn't improve in the first proning session? So then like okay, let us prove it beyond doubt. So we did a VQ scan because the patient was stable by that time, and it was showing 90% probability of thrombosis in the area. So it was actually microthrombosis which improved. VQ scan we do once in a year probably. Again, people were not believing. So in hospital, patient developed. There is no photograph. This. So this is a definite indication that the patient is having a state of hypercoagulability and microthrombus. Now, at this point of time, everyone was convinced that it is the microthrombus. It's important if you go into the literature of scrub typhus, the risk of acute coronary events after an episode of scrub typhus is 2 to 3 times higher than general population in next 6 months. So we discuss a lot about this in COVID, but most of the tropical febrile like leptospira can cause actually CKD, irrespective of whether it is causing AK or not. There is a higher incidence of CKD. Scrub can cause increase in coronary artery events. This is very interesting because leptospira we don't discuss about immune thrombosis. We discuss more about diffuse ulnar hemorrhage, but this turned out to be immune thrombosis. Last cases. This is very interesting, very common in KMC Manipal. I don't know. I think in this place also people must be knowing there is something called thiamine-responsive acute pulmonary hypertension. An alcoholic patient who is a fisherman who will go to the sea, have a lot of fish, seawater fish, which will have a lot of thiaminases, and he will come back to the emergency with shock, refractory shock. And the numbers you will see will be like something like this. The pH is 6.9 and bicarb is like 3. 3 bicarb is always, even DK you will see above 5. So 3 is like toxin, someone has poisoned him, and lactates are quite high. So anyone who comes to KMC, when they see this case for the first time, they're like, he's going to die. And you suddenly surprisingly see all the physicians are very comfortable treating this patient, labeling it as TRAF. So if you do a echo, the RA-RV will be ballooned. Many patients get a CTPA because the new physician who comes, he wants to rule out pulmonary embolism at any cost. They do a CTPA, it will be clean. You give thiamine, little bit of bicarb and fluids. Within 12 to 24 hours, patient will be out of ICU to the ward. And this has happened many times. We thought we will report it. We reported 8 cases, and you can see the numbers, which can be very deceptive. There is one more case, but this is Dr. Naveed Vig, who is my teacher. This is Natin Gupta, home with your work. This is Rachna, who is my wife, and I keep irritating her whole the day with all these concepts which she don't want to listen to. That is Dr. Manish Sunejza, and some are my residents, Swati Kiran Anjali. I made them work a lot for all these cases. Thank you very much.
Thank you, sir, for your wonderful start to this conference with your thoughtful words.
Maybe I'm happy that many people are still awake, but it is a great, excellent talk.
Thank you. Sir, yeah.
When you talk about chronic active EBV, there are two aspects to it. One is that this could be active
EBV.
in the B cells or it could be in the NKT cells. Now, if it is active in the B cells, then PD suppression
It will
sounds
still
like
work.
a good idea, right? But if it is active in the NKT cell variant, then actually you might be worsening the inflammatory pathway there, right? Because PD to a certain extent is actually restraining the.
So the idea is if you block the PD-1 blockers, the cells which are infected with EBV will be killed by other CD8 and NK cells. So basically EBV is increasing the expression of PDL1 on infected cells, and that PDL1 is causing immunoparalysis of the rest of the cells which are actually supposed to work against the cells. So actually all the case series with the 75-80% is actually from chronic active EBV with NKT cells. B cell, it is interesting. B cell, we can actually take another approach, like you can give rituximab because it will sell B cells.
Yes.
But again, you can do that also. But in most of the lymphomas, which are EBV associated lymphomas, even checkpoint inhibitors will work. Ideally, you should confirm, do a biopsy and do a EBER on the surface and see which cell it is. We were not
EBER-ish or cell sorting should be done for these things.
Yeah, we should be doing so that we will know which cell it is. But I think checkpoint inhibitors will work for both. But if it is B cell EBV, rituximab is a safer option. As you said, that in a state of HLH with hyperinflammatory phenotype, if you are giving a checkpoint inhibitor, you might really drive the crisis at that point of time. So this patient, what we did is we went for etoposide to control along with steroids, and we started on JAK inhibitors. We started on tofacitinib, and we tried, because tofacitinib again it has a STAT3 inhibition activity which is very important for EBV. So we tried to cool down that first before actually giving the first dose of checkpoint inhibitors, and we actually went for a very low dose, 40 mg of checkpoint inhibitors.
That's interesting, because whenever we have had chronic active EBVs, especially T cells, usually what we have done is gone for bortezomib and transplant.
Yeah.
Unless they are actively having HLH at that time, but that's when we have actually stayed away from nivolumab.
Yeah.
What you're saying is interesting.
So this concept of bortezomib with ganciclovir is also very interesting, because in EBV, the ganciclovir will not work because it will not be in lytic cycle. So what you can give is, you can give a ubiquin proteasome inhibitor called bortezomib, which we use in multiple myeloma, that will make the EBV go into lytic cycle, and then you give ganciclovir to kill the virus.
Exactly.
We tried it for a couple of cases, it didn't work for us.
So we have tried it for 3 cases. I mean, bortezomib plus ganciclovir, and then taking them for
transplant,
an allogenic transplant.
Yeah,
yes.
Our patients, they don't want to go for transplant. So we have at least 2 cases who are in chronic long-term maintenance of EBV. It is possible that that EBV clone will switch to other immune pathways, and then nivolumab might not work in the future. But for now, it is working for us. Yes.
So even in the face of HLH and chronic NKT cell EBV variant, you would be okay trying?
Yes, sir. Both of our cases were in active HLH where we are giving.
Thank you. Excellent presentation. Thank you. We learned a lot.
Thank you.
You were talking about the leptospiral case.
Yeah.
So what was the platelet, at what level you were giving the anticoagulants?
Yeah, so this was a very important question, because thrombocytopenia is an issue. So what happened is, once we gave steroids, the platelets actually from 20,000 they increased to 47,000. They were in increasing trend. It's not like after anticoagulation it has increased, but it's still below 50. So at 47,000, we started on prophylactic dose of enoxaparin only, but next day it jumped to 80,000, where we switched to enoxaparin 40 mg BD dose, which is the intermediate dose of enoxaparin.
So last Friday we had a medical student, third year medical student, typical case of leptospirosis, 21,000. Was admitted within 8 hours. He worsened, put on NIV, and he was not maintaining saturation of even 80% on NIV. We had to intubate him, and even after intubation, his PF ratio was less than 140. He was having severe DAH actually.
Achha, it's a DH phenotype, yeah.
So we didn't go for prodding actually because
Difficult with hemoptysis, it keep coming in ET tube, yeah.
So we straight away went for ECMO actually.
That is a great idea.
So we because now this morning I discussed with Jacob actually, because we gave we were not sure how much of steroids to give, whether it will work or not actually. So how will you decide whether in DH what exactly to do?
Sir, I will. This is very important because I'm going to say that there is no data for steroids. That's what I'm going to say. But again, if you see everything in a strict way, there is no data for managing tropical ARDS. Leptospira ARDS, you don't have any papers. What PEEP to give? What should be the ventilatory setting? Whether we go for a high PEEP strategy. So there is no data everywhere, not even for steroids. And everyone who is managing leptospira, they know that steroids work. So steroids has to be given, and you can always say that there is a ARDS data where steroids are shown to be beneficial. So steroids have to be given. The question is, what is the dose of steroids? Now here we have to understand a thing that rheumatology colleagues and transplant people who are dealing with transplant, they used to give 500 mg 1 gram. Now they understood that 500 mg 1 gram is not required. They came down to 125, and most of the transplant protocols you see, with rare exceptions, the initial dose to prevent the reperfusion injury will be either 125 mg of methylprednisolone or 250 mg of methylprednisolone. This they do because steroids have non-genomic effects. Like for example, methylprednisolone will have its non-genomic effects, which will start at 125 mg, which will get sealed at 500 mg. If you give above 500 mg, there is no benefit even in the terms of non-genomic effects. And the genomic effects of steroids will take at least 2 days to kick in. So you need some time. So first couple of days, a DH 125 mg or 250 mg of methylprednisolone is okay. But then I think once you anticipate that the genomic effects of the steroids will kick in, you should come down on the dose of steroids. And once the patient is stable, rather than prolonging them, trying to taper the steroids slowly, I think steroids can be stopped quicker. The worry is rebound inflammation all the time. Many times we use midodrine or fludocortisone just to prevent a rebound hypotension. And if the CRP is going little high, we understand that it's because of the steroid taper. Unless the patient is desaturating, we will not hike up the steroids. So we will try to keep the steroid doses here around 5 to 7 days, not more than 250 mg. 500 mg is also a little bit overkill. Now the problem is all these patients with leptospira and DH are going to get Acinetobacter, and these patients who are difficult to ventilate will require a muscle relaxants. So when you are giving etraqueum, high dose of steroids, and then you are giving polymyxin, and then you see that the patient is not moving all his limbs for long time, you do tracheostomy, but it will be very difficult to take him off ventilator even after tracheostomy. He will get one or other infection. That's the normal course. So that's why the tropical sepsis is very important. It's so different from what we see. These are the young people. You are able to do ECMO. Many times these are the young people who are going and working somewhere. For example, KFD, all they go to forest. If they have money for ECMO, they will not go. These patients sometimes develop fulminant myocarditis. The only way you can treat fulminant myocarditis is support the heart, give the heart rest. So you either have to use Impella or ECMO or combine them to make ECPella, and which we will not be able to do because the patient is no way affording. So these patients die because of this. I think it is a very important area to work and improve the outcomes of our young generation who are very actively working. Thank you. Thanks for that question, sir. Thank you very much.
Any other questions? Thank you, Praveen.
Thank you, sir. Up next, we have a section on leptospirosis in ICU, diagnostic pearls and pitfalls by Dr. Sajid Kumar R., who is a professor emeritus in the Department of Infectious Disease in Government Medical College, Kottayam. He is associated with the first DM program in infectious disease in State Government Medical College, and he is highly respected infectious disease specialist with vast clinical and teaching experience. We are delighted to welcome Dr. Sajid to this conference. Sir, please.
I should place on record that sir is extremely busy with some personal reasons, and he almost refused to come today. But again, I had to plead him, sir, you have to come. And sir gracefully accepted my invitation. Thank you so much, sir, for being here.
Thank you, Dr. Jacob. I must say I am here mostly because of my love to Jacob rather than about my commitment about the topic, because as he said, I was quite busy. I'm quite fortunate that I could be here on the fine morning of the first day of the CME. And not only that, because Praveen has already covered most of what I was supposed to say. So leptospirosis, as all of you know, is an issue that keeps coming to us, all of presenting in different ways. And I'm sure there will be no physician in this group who has not seen a case of leptospirosis or who has never suffered from the regrets after the patients have left us. Even though such a common disease, it happens regularly in our environment and is always causing confusion to all of us. And there have been large number of studies based on this. And most of the infections are mild or non-specific. If you speak to people who have recovered from leptospirosis, most of them will tell you there is nothing to worry about in leptospirosis. And most of the physicians and general practitioners have got ample experience in handling the so-called asymptomatic or perhaps mildly symptomatic leptospirosis cases. But a few of them can develop serious disease. And it is this small group which actually ends up in ICU, and that is the set of people whom we are going to handle. I'll not be going into the detailed analysis of the pathogenesis and other aspects about this, but I'll be discussing only about the pitfalls that can happen during the diagnosis. And okay, the classic case is something like this. A working person, male or female, presents after a monsoon flood exposure, or even sometimes, after what we call as urban leptospirosis, which can happen following floods and sudden outbursts, just like what we are having right now. And he comes with the classical features of fever, myalgia, conjunctival congestion, slight thrombocytopenia, significantly elevated bilirubin, mild elevation of creatinine, and mild dyspnea. And of course, you have the list of diseases which are listed on the other side, which can always be there in your mind whenever you see a patient with tropical fever. And the list goes on, being added every now and then, just like Praveen was telling. KFD is not that common perhaps for our patients, but there are so many other variants of illnesses which can happen in between also. And then the classical diagnostic test will definitely tell us mostly about the disease of leptospirosis, but the phenotype itself is very specific. There is not much confusion about the initial results which come to us, and the classical presentation with all these features will always tell you that this is probably a case of leptospirosis. And some of those things, which have become unpopular, like the dark field microscopy and culture, are not used anywhere. And the classical textbook description of MAT and MAT1, they are also practically out of question nowadays, so that we are always holding on to the IgM leptospirosis or the PCR, which is available now. Now, the usual trigger for ICU admission is any of these, almost any of these, because leptospirosis, as all of us know, affects younger individuals, people of the working population. So we want them to go into a very serious stage at a very early stage of the disease itself. So even if you find any one of these features, it is an indication to get the patient into the ICU. And of course, this is a disease with multi-organ failure, severe thrombocytopenia and bleeding, and not to forget about the metabolic acidosis and the other problems which can happen with this. So coming to the issues that we occasionally see in these patients, this is a patient who is admitted with classical feature of leptospirosis. But if you look into this, are you finding anything which is not in conjunction with what we usually expect? Acute kidney injury is the standard in many cases. As you can see in this case, the patient has come with a creatinine value of 2.8 with all other features suggestive of that. But if you look carefully, you'll find something which is not usually expected, a hypokalemia in this patient. Usually in case of AKI, what you find is actually hyperkalemia. And why do these patients get hypokalemia? This is not a very common phenomenon that is seen, but this can happen because of the changes that can happen in the proximal tubule damage, resulting in increased sodium load where it is exchanged for potassium, which leads to hypokalemia. So it's not that hyperkalemia is not always the role, even though we classically teach our students that hyperkalemia classically happens with AKI along with jaundice. Hypokalemia can also happen in these patients. Another patient where a 46-year-old man with suspected leptospirosis, he is admitted to the ICU with tachypnea, all those features. Chest imaging shows bilateral infiltrates and the patient has rising oxygen requirement. Now, the patient has got acidosis, patient is going in for renal failure, patient is already in renal failure, and chest is showing findings. The main question is whether acidosis is predominantly renal, lactic, respiratory, compensated or mixed. Well, severe metabolic acidosis can happen in ICU leptospirosis cases, and this is perhaps the one which we have to be most worried about. I'm reminded of the olden days when, during our postgraduate days, the only concern that we had in patients with leptospirosis was renal involvement. And we always waited for creatinine to go up, we always waited for oliguria to develop, we always waited for anuria to develop before we actually took the patient as a serious patient. But now we are switching gradually towards looking at the multifactorial origin of metabolic acidosis in these patients and look for lactate levels, look for reduced renal acid excretion, hyperphosphatemia, and chloride load, which can happen from resuscitation, all of which can contribute to the metabolic acidosis. Tachypnea may represent the respiratory compensation and is also a marker associated with ICU admission. And management priorities, of course, are related to the source-directed treatment, hemodynamic optimization, cautious fluids, not overloading the patients with fluid all the time, vasopressors when needed, and oxygenation. So RRT thresholds have been well defined. We are all familiar with these RRT thresholds: refractory hyperkalemia, severe metabolic acidosis, fluid overload causing respiratory compromise, uremic complications, persistent oliguria, anuria with worsening acidemia, and volume or electrolyte derangement. And the practical triggers for all practical purposes when we are working in the wards: potassium of more than 6 millimoles per liter or rising despite therapy, pH less than 7.1, or refractory lactate acidosis, pulmonary edema or inability to maintain oxygenation because of volume overload, symptomatic uremia, encephalopathy, pericarditis, or uncontrolled bleeding tendency with renal failure must be taken care of. And these patients are definitely indicated for dialysis. These are the metabolic indications which are suggested there, and it's about 14.4% of patients who require dialysis. And ICU metabolic goals include stabilization of acid-base status, potassium control, and support of multi-organ recovery. So what we have to do perhaps in the ICU in relation to the renal parameters is to review the urine output, interpret the acid-base status as early as possible, and remember that metabolic deterioration may precede over overt uremic symptoms. So we must be on the watch out for metabolic problems in these patients rather than waiting for the overt uremic symptoms to happen. This is another patient. The difference here from other patients is that this is a patient who is showing atrial fibrillation with rapid ventricular response, and bedside echo reveals global LV hypokinesia with reduced ejection fraction. Myocarditis in leptospirosis is a well-recognized entity, and cardiac involvement can occur early, maybe occult initially, but can occur early and can manifest with disproportionate tachycardia, hypotension, arrhythmia, myocarditis, or shock. And cardiac involvement contributes to adverse outcome. And one of the things we have to be very, very careful in this is that we have to restrict the further fluids in these patients, go for continuous telemetry, use of proper antibiotics, which is of course the standard, electrolyte correction, and early renal support planning. They may manifest with sinus tachycardia, atrial fibrillation and flutter, AV block, non-specific STT changes, reduced LV function, and rarely fulminant cardiogenic shock. And let us not forget that leptospirosis is always a multi-organ disease, so they may coexist with AKI, pulmonary hemorrhage, ARDS, thrombocytopenia, making early diagnosis easy to miss. There are different mechanisms suggested for myocarditis in leptospirosis patients admitted to ICUs. It could be due to a direct myocardial inflammation, vasculitic or endothelial injury, systemic inflammatory response, electrolyte derangement, and all the other causes. The classical recommendation is to go for echo before fluids. Serial reassessment is needed. Shock phenotyping is needed for these patients. And in many patients, the cause of shock could be mixed. So a combined vasopressor inotrope strategy may be more physiologic than fluids plus escalating norepinephrine alone. Now, continuous telemetry is perhaps recommended in all patients with rhythm abnormalities. Treat unstable tachyarrhythmia or bradyarrhythmia according to the standard principles and correcting the underlying metabolic and inflammatory drivers. Avoid fluid overload in patients with concomitant pulmonary hemorrhage, ARDS, or LV dysfunction. The next issue that we have in the ICU is the patient with respiratory problems, which was not that common in the earlier days, but is now becoming the major killer in leptospirosis. And respiratory problems can manifest with any of these features. Continue oxygen, start monitoring the oxygen levels. Trial for a non-invasive ventilation, high flow nasal oxygen or mechanical ventilation as needed for these patients, and intubate with lung protective strategy, prone positioning, and as we discussed before about ECMO. When to intubate, there are definite indications. When there is refractory hypoxemia, marked tachypnea or respiratory distress, massive hemoptysis or pulmonary hemorrhage, altered mental status or low GCS, and of course, when the patient is likely to go into ARDS. There are questions about some questionable therapies. One among them is the plasmapheresis. Routine plasmapheresis is not currently supported by current evidence. There's one small clinical trial is there, plus a few case reports which suggested whether plasmapheresis might work. But in select patients with severe icteric leptospirosis, multi-organ failure, pulmonary hemorrhage, plasmapheresis might be useful. Corticosteroids, we had a very detailed discussion by Dr. Praveen about how to use corticosteroids and when to use corticosteroids. Of course, as he has rightly said, the evidence is limited and controversial, but may be considered in select patients. And he has discussed about the various factors. ECMO also, we had some discussion about how and when ECMO can be used, but the major problem again happens to be the cost that is involved in this and the issue about how the patients are going to be selected for ECMO and how they are going to be weaned out of ECMO. So consider ECMO when severe ARDS with refractory hypoxemia despite optimized ventilation and proning, inability to maintain safe oxygenation and ventilation with conventional IC support, potentially reversible lung injury and available ECMO expertise, which is very important. And active leptospiral infection perhaps is not a contraindication. It's definitely a situation where this can be used, even though again reports are few. Now, 2026 ICU care for leptospirosis is based on these parameters. One is phenotype based ICU care. So severe leptospirosis, initially we call this as Wheals disease, Wheals syndrome, this and that, but now we know that it can be a combination of any multi-organ involvement. And prognostic markers have to be always kept in mind: older age, altered mental status, respiratory insufficiency, and oliguria. And supportive care is more explicit. Early diagnosis is important, earlier recognition, earlier confirmation, and earlier escalation. Earlier diagnosis is more structured these days with PCR, which is emphasized in the first few weeks of the illness. Then the second issue is about treat on suspicion, not confirmation. There are so many other differential diagnoses that we have to keep when we get a patient with leptospirosis. But the treatment, the antibiotic choice, which is very, very specific for leptospirosis, must never be forgotten. ICU triage is more phenotype driven. Early recognition of pulmonary failure, oliguric AKI, altered mental status, and hemodynamic instability. And a faster pathway from suspicion to testing, early antibiotics, closer prognostic stratification, and earlier escalation of organ support will definitely help us. There are scores which are recommended these days. You have the prognostic scoring, which is recommended. You have the Spiro scores, the Pongpan predictors, and perhaps the modified Fain's criteria, etc. And also the general critical care and sepsis scores, which most of us are familiar with, can be used for prognostication in these patients. And there are a large number of scientific reports also where the mortality in leptospirosis can be predicted to a large extent based on these scores. I'm not going to the details of that. So the 5 ICU pitfalls which I would like to leave behind with you is delayed suspicion. in the case of syndromic tropical fever, that means going in for early diagnosis, waiting for laboratory confirmation before treatment is not required in any of these cases. Over resuscitating the patients, drifting towards lung failure is prone to happen, as Praveen has already rightly pointed in one of the discussions. Missing pulmonary hemorrhage until late. By the time the patient develops pulmonary hemorrhage, it is too late to act. And we had in many instances seen patients during the rounds itself developing pulmonary hemorrhage and collapsing in front of us. Waiting too long before ICU transfer or RRT should be avoided. Of course, we also are progressing towards in the field of leptospirosis management. Now we have the NCDC guidelines which are just being brought out. And of course, this is going to help us a lot in managing these patients in large numbers to prevent a mortality in a situation that affects the common man, the common working man on a regular basis, where we will definitely be able to help the patient because we have got standard protocols available for almost all entities associated with leptospirosis. Thank you very much.
For leptospirosis, especially in initial stages, do you wait for, obviously you don't wait, but would you want to wait to confirm the diagnosis later, 7 days, 8 days, would you want to send a 15 status? Because if a death happens, the government is very much insistent of a PCR-based diagnosis of leptospirosis to report it. So should we be doing it earlier?
No, the current trend is that if you are clear conviction about the case of leptospirosis, you can always wait for the IgM lepto to become positive and you can wait for that. But in any case where there is going to be a doubt, we have got lepto-PCR available now. Even in our institution, we have got facility to do the lepto-PCR. In Kerala, there are at least 3 or 4 centers where they are doing lepto-PCR on a regular basis. So there need not be any hesitancy to send the sample for lepto-PCR in the first week itself, unless in a situation where you are damn clear about the diagnosis. Definitely.
How many days can you send the leptospirosis?
Manju, what is the practice now?
You send a dedicated lepto-PCR or a tropical PCR panel?
Yeah, in fact, many patients we end up sending both.
So is there any problem with the sensitivity of when it is combined together?
Now we have a problem because right from the days when we were using only IgM serology for testing leptospirosis and other tropical fevers, there's a lot of cross reactivity that does happen. There's a lot of cross reactivity, so the sensitivity is pretty high, but specificity sometimes is low, and that really puts the physician at a confused state in the initial days. But that is where probably your other tests like CRP, calcitonin, etc. can perhaps help you. Yes.
But what about PCR? Is it
sensitivity going down if it is a part of multiplex, or if you do dedicated? Is there any difference, anything reported on this? I am not aware.
No sir, no, we haven't come across that situation. It is highly sensitive and specific,
even when it is a part of multiplex.
yes.
Sir, in general, when we multiplex anything, like you have many targets, automatically the sensitivity for the particular thing will come down. If it is a dedicated PCR, the sensitivity will be way better than a multiplex.
Yeah, that is a generic observation. Thank you.
Thank you, sir. Thank you so much. So next is our inauguration. Yeah, Achin is just on the way. Meanwhile, while we wait for Achin to come and inaugurate, I request all of you to participate in that pre-test that is being done. Till now, I have received only 25 responses. I request all of you to complete the pre-test. because that's important for us to send your attendance to the TCMC council also. So please complete the pretest ASAP. I reset the timer for the same.
Next section on optimizing antimicrobial therapy in the ICU, PKPD, therapeutic drug monitoring and precision dosing in critical illness by Dr. Parshit, who is a well-known infectious disease specialist with expertise in sepsis, transplant infections and resistant infections. He has received advanced training in infectious disease and transplant infectious disease from United States and is widely respected for his clinical expertise, dedication to patient care, and contributions to medical education. We are honored to have Dr. Parishit with us today to share his insights and expertise. Sir, please.
Yes. Good morning, everyone, and thank you for inviting me again to this lovely conference. We had a great time last year when we were here for the FISF course. So I'm going to be talking about optimizing the PKPD. Yeah. Yeah, that's what I thought.
With utmost respect, let me invite our Joint Director, Reverend Father Joyce Nandikunnel, to inaugurate this conference by lighting the lamp and to address the gathering. I request all the dignitaries to come forward to join for lamp lighting.
എല്ലാവർക്കും ഗുഡ് മോർണിംഗ്. യെസ്, എല്ലാവരും വളരെ പവർഫുള്ളായിട്ട് വളരെ എനർജിയോടുകൂടിയാണ് നിങ്ങൾ ഇവിടെ ആയിരിക്കുന്നത് എന്ന് എനിക്കറിയാം. ആദ്യമേ തന്നെ നമ്മുടെ കാരിത്താസ് ഹോസ്പിറ്റലിലേക്ക് സ്നേഹത്തോടുകൂടി എല്ലാവരെയും സ്വാഗതം ചെയ്യുകയാണ്. കാരിത്താസ് ഹോസ്പിറ്റൽ തുടങ്ങിയിട്ട് 65 വർഷമായി. ഈ 65 വർഷത്തിലേക്ക് പ്രവേശിക്കുമ്പോൾ 50 ബെഡിൽ തുടങ്ങി ഇപ്പോൾ 655 ബെഡിലായിട്ട് ഈ ഹോസ്പിറ്റൽ നിൽക്കുകയാണ്. അപ്പം ഇവിടെ ആയിരിക്കുമ്പോൾ എനിക്കറിയാം ഇന്ത്യയിൽ നിന്നുള്ള വിവിധ സ്ഥലങ്ങളിൽ നിന്നുള്ളവർ ഇവിടെ എത്തിച്ചേർന്നിട്ടുണ്ട്. അപ്പോൾ എല്ലാവർക്കും ഒറ്റ വാക്കിൽ കാരിത്താസ് ഹോസ്പിറ്റലിൻ്റെ പേരിൽ സ്വാഗതം ആശംസിക്കുകയാണ്. അതുപോലെ തന്നെ ഞാൻ ഈ ഇൻ്റർവെൽ സമയത്താണ് ഇപ്പോൾ ഇവിടെ ഈ മീറ്റിങ്ങിന് ഇപ്പോൾ ഇവിടെ എത്തിയത്. അപ്പോൾ ഞാനിവിടെ ഫ്രണ്ട് സീറ്റിൽ ഇരുന്നപ്പോൾ സാധാരണ നമുക്കറിയാം ഇൻ്റർവെൽ സമയത്ത് നമ്മൾ ഇങ്ങനെയുള്ള CMEസിനൊക്കെ വരുമ്പോഴാണ് നമ്മൾ പരസ്പരം കൂടുതൽ പരിചയം പുതുക്കുന്നതും പരിചയമുള്ളവരെ കൂടുതലായിട്ട് അടുത്തറിയുന്നതും നമ്മുടെ പേഴ്സണൽ ആയിട്ടുള്ള സംസാരമൊക്കെ കൂടുതലായിട്ടും ഇങ്ങനെയുള്ള അവസരങ്ങളിലാണ് ഉണ്ടാകുന്നത്. അപ്പം ഞാനിവിടെ ഫ്രണ്ടിലത്തെ സീറ്റിൽ സജിത്ത് സാറിൻ്റെ സൈഡിലാണ് ഇരുന്നത്. അപ്പോൾ എൻ്റെ തൊട്ട് പുറകിലിരുന്ന ഡോക്ടേഴ്സ് എന്താണ് സംസാരിക്കുന്നത് ഞാൻ നോക്കിയപ്പോൾ അവർ സംസാരിക്കുന്നത് തന്നെ ഇൻഫെക്ഷൻസിനെ കുറിച്ചാണ് അവർ സംസാരിച്ചുകൊണ്ടിരിക്കുന്നത്. ഞാൻ ഓർത്തു അവർ വേറെ എന്തെങ്കിലും കാര്യങ്ങളായിരിക്കും, കാരണം മീറ്റിങ്ങിൽ നമ്മുടെ ഡിസ്കഷൻ മൊത്തവും ഇൻഫെക്ഷനെ കുറിച്ചാണ്. പക്ഷെ ഞാൻ അവിടെ ഇരുന്നപ്പോൾ അവർ സംസാരിച്ചുകൊണ്ടിരുന്നവർ രണ്ടുപേര് സംസാരിച്ചുകൊണ്ടിരുന്നത് ഇൻഫെക്ഷൻസിനെ കുറിച്ചാണ്. അപ്പോൾ ആ സമയത്ത് കൊടുത്ത മെഡിസിനെ കുറിച്ചും അതിൻ്റെ കാര്യങ്ങളാണ് സംസാരിച്ചുകൊണ്ടിരുന്നത്. അപ്പം തീർച്ചയായിട്ടും നമ്മുടെ ചിന്തയിലും നമ്മുടെ പ്രവൃത്തിയിലുമെല്ലാം തീർച്ചയായിട്ടും പേഷ്യൻസ് കെയർ, നല്ല പേഷ്യൻസ് എക്സ്പീരിയൻസ് കൊടുക്കുക എന്നുള്ളതാണ് നമ്മുടെ എല്ലാവരുടെയും ലക്ഷ്യം. അപ്പം നമുക്കറിയാം ഇൻഫെക്ഷൻസിനെ കുറിച്ച് നമ്മൾ ചിന്തിക്കുമ്പോൾ വിവിധ തരത്തിലുള്ള ഇൻഫെക്ഷൻസ് ഉണ്ട്. അതുപോലെ തന്നെ ഇൻഫെക്ഷൻസ് ഡിസീസ് ഇതെല്ലാം നമുക്കുണ്ട്. അപ്പോൾ ഇവിടെ നമ്മുടെ ക്രിട്ടിക്കൽ കെയർ ഡോക്ടേഴ്സും അതുപോലെ തന്നെ നമ്മുടെ ജനറൽ മെഡിസിൻ ഡോക്ടേഴ്സ് അതുപോലെ തന്നെ ID ഡോക്ടേഴ്സ് എല്ലാവരും ഇവിടെയുണ്ട്. അപ്പോൾ അതുപോലെ തന്നെ നമ്മുടെ ഇന്ത്യയിലെ തന്നെ പ്രഗത്ഭരായ ഡോക്ടേഴ്സ് ഇവിടെ സന്നിഹിതരായിട്ടുണ്ട്. വളരെ എക്സ്പെർട്ട് ആയിട്ടുള്ള ഡോക്ടേഴ്സ് എല്ലാവരും ഇവിടെയുണ്ട്. ഡോക്ടർ സജിത്ത് നമ്മുടെ കാരിത്താസ് ഹോസ്പിറ്റലിൽ തന്നെ ഭാഗമാണ്. നമ്മുടെ കാരിത്താസിൻ്റെ മാത്രമല്ല മറിച്ച് നമ്മുടെ കേരളത്തിൻ്റെ ഗവൺമെൻറ്റോടുകൂടി ചേർന്ന് നിന്നുകൊണ്ട് നമുക്കറിയാം കോവിഡ് പാൻഡമിക്കൊക്കെ ഉണ്ടായ സമയത്ത് ഏറ്റവും കൂടുതൽ പ്രവർത്തനം കാഴ്ച വെച്ച വ്യക്തിയാണ് ഡോക്ടർ സജിത്ത് സാർ. അപ്പം നല്ല ഒരു കയ്യടി നമുക്ക് കൊടുക്കാം. അതുപോലെ തന്നെ സാറിൻ്റെ കൂടെയുള്ള നമ്മുടെ ഡോക്ടർ കൂടെ ഇരിക്കുന്ന ഡോക്ടറിൻ്റെ കാര്യം പറഞ്ഞു. അപ്പോൾ 40 വർഷക്കാലമായിട്ട് അവർ തമ്മിൽ പരിചയമുണ്ട്, അവർ തമ്മിൽ സംസാരിക്കുന്ന ആളെന്നാണ്. 40 years ഓഫ് എക്സ്പീരിയൻസ് അല്ലെങ്കിൽ 40 years ഓഫ് ഫ്രണ്ട്ഷിപ്പ് അവർ തമ്മിലുണ്ട്. അപ്പോൾ ഇൻ ദ നെയിം ഓഫ് ഓൾ ഹു ഗ്യാതേർഡ് ഹിയർ ഐ വെൽക്കം യു സാർ ടു ദിസ് അവർ ഹോസ്പിറ്റൽ. അതുപോലെ തന്നെ നമുക്കറിയാം എന്തുകൊണ്ടാണ് ഇവിടെ ഇരിക്കുന്നത് നിങ്ങളെല്ലാവരും. നമുക്കറിയാം പല പ്രൊഫഷൻസ് ഉണ്ട്, നിങ്ങളെല്ലാവരും ഡോക്ടേഴ്സായിട്ട് മാറി എന്നുള്ളത് ഏറ്റവും പ്രധാനപ്പെട്ട കാര്യം. അതുപോലെ തന്നെ എന്തുകൊണ്ടാണ് നിങ്ങളിൽ ചിലർ ഈ ക്രിട്ടിക്കൽ കെയർ ഡോക്ടേഴ്സ് ആയിട്ട് മാറിയത്? എന്തുകൊണ്ടാണ് നിങ്ങൾ ആ ഡിപ്പാർട്ട്മെൻറ്റ് സെലക്ട് ചെയ്യാനുള്ള കാരണം? നമുക്കറിയാം നമുക്ക് യാദൃശ്ചികമായിട്ട് ആക്സിഡൻ്റലായിട്ടല്ലല്ലോ നമ്മൾ ഓരോ ഡിപ്പാർട്ട്മെൻറ്റുകളിലേക്കും നമ്മൾ എത്തുന്നത്, മറിച്ച് നമ്മളെല്ലാം എത്തുമ്പോൾ നമുക്ക് ഒരു സ്വപ്നമുണ്ട്, ഒരു ഡ്രീമുണ്ട്, അതനുസരിച്ചാണ് നമ്മൾ മുൻപോട്ട് നീങ്ങുന്നത്. എന്തുകൊണ്ടാണ് നിങ്ങൾ ജനറൽ മെഡിസിൻ അല്ലെങ്കിൽ ക്രിട്ടിക്കൽ കെയറിൽ നിങ്ങൾ തിരഞ്ഞെടുക്കാനുള്ള കാരണം? അപ്പം നമുക്കറിയാം നമ്മൾ എപ്പോൾ നമ്മൾ റിസ്ക് എടുക്കുന്നോ അതനുസരിച്ച് നമുക്ക് വിജയം ഉണ്ടാവും എന്നാണ് പറയുന്നത്. അപ്പോൾ ഒരു വളരെ ചലഞ്ചിങ് ആയിട്ടുള്ള ഒരു ഏരിയയാണ് ക്രിട്ടിക്കൽ കെയർ ഡോക്ടേഴ്സ് എന്ന് പറയുന്നത്. അപ്പോൾ അതുകൊണ്ട് ഒരു ഹെൽത്ത് ഫീൽഡിലും നിങ്ങൾ വളരെ ക്രിട്ടിക്കൽ ആയിട്ടുള്ള ഡോക്ടേഴ്സാണ്, വളരെ ബെനിഫിഷ്യൽ ആയിട്ടുള്ള ഡോക്ടേഴ്സാണ്. കാരണം നിങ്ങളുടെ മുൻപിൽ വരുന്ന പേഷ്യൻസ് പലപ്പോഴും മരണത്തോട് മല്ലടിച്ച് ജീവിക്കുന്നവരായിരിക്കും, അല്ലെങ്കിൽ അതേപോലെ ലൈഫ് ഒത്തിരി സേവ് ചെയ്യുന്ന ലൈഫ് സേവേഴ്സ് ആയിട്ട് മാറുവാനായിട്ട് നിങ്ങൾക്ക് സാധിക്കും. അതുകൊണ്ട് നിങ്ങളെ കൺഗ്രാജുലേറ്റ് ചെയ്യുന്നു. അതുപോലെ തന്നെ ഈ അവസരം പ്രത്യേകമായിട്ട് അഭിനന്ദിക്കുകയാണ്. കാരിത്താസിലെ ക്രിട്ടിക്കൽ കെയർ ടീമിന് നേതൃത്വം വഹിക്കുന്നത്, അതിൻ്റെ ലീഡർഷിപ്പ് നമ്മുടെ ഡോക്ടർ ജേക്കബാണ് ഞങ്ങളുടെ ക്രിട്ടിക്കൽ കെയർ ടീമിൻ്റെ ബാക്ക് ബോൺ ആയിട്ട് നിൽക്കുന്ന വ്യക്തി. അപ്പോൾ ഈ ഒരു CMEക്ക് വേണ്ടി അദ്ദേഹം വളരെയധികം കഷ്ടപ്പെട്ടു, രാപ്പകല് അധ്വാനിച്ചു. അതായത് ഏകദേശം ഒരു 40-50ഓളം വാട്സപ്പ് ഗ്രൂപ്പ് തന്നെ അദ്ദേഹം ഉണ്ടാക്കി. ഈ വാട്സപ്പ് ഗ്രൂപ്പിൽ കൂടിയായിരുന്നു കമ്മ്യൂണിക്കേഷൻസ് എല്ലാം നടത്തിക്കൊണ്ടിരുന്നത്. പാർട്ടിസിപ്പൻസിന് വേണ്ടി ഒരു വാട്സപ്പ് ഗ്രൂപ്പ്, അതുപോലെ തന്നെ ഇവിടെ വരുന്ന നമ്മുടെ റിസോഴ്സ് പേഴ്സൺസിന് വേണ്ടി അവർക്കൊരു വാട്സപ്പ് ഗ്രൂപ്പ്, ഇങ്ങനെ വാട്സപ്പ് ഗ്രൂപ്പുകളെല്ലാം ഉണ്ടാക്കി വളരെ. അതോടൊപ്പം ഞങ്ങളുടെ ഒരു മെഡിക്കൽ സൂപ്രണ്ട് കൂടിയാണ് ഡോക്ടർ ജേക്കബ്. അതുപോലെ തന്നെ ഞങ്ങളുടെ ഇവിടെ ക്രിട്ടിക്കൽ കെയർ ഡോക്ടേഴ്സിൻ്റെ ഒരു ടീം 20ഓളം വരുന്ന ഡോക്ടേഴ്സ് ഇവിടെ ഉണ്ട്. അവരുടെ എല്ലാവരുടെ ഒരു ഇനിഷ്യേറ്റീവാണ് തീർച്ചയായിട്ടും ഇവിടെ ഉള്ള. അതുകൊണ്ട് ഡോക്ടർ ജേക്കബിന് ഒരു മാസ്റ്റർ ബ്രെയിനാണ്. അപ്പോൾ അതുകൊണ്ട് ഡോക്ടർ ജേക്കബിനും ഇപ്പം നമുക്ക് ഒരു കയ്യടി കൊടുക്കാൻ പറ്റും, നല്ലൊരു ക്ലാപ്പ് കൊടുക്കാം. യെസ്. അപ്പോൾ ഇനി വിലയേറിയ സമയം ഒരിക്കലും കളയുന്നില്ല. അപ്പോൾ അതുകൊണ്ട് നിങ്ങൾക്ക് എല്ലാവർക്കും ഈ 3 ദിവസത്തെ കോൺഫറൻസ് നല്ല ഒരു എക്സ്പീരിയൻസ് ആയിട്ട് മാറട്ടെ. പുതിയ പുതിയ കാര്യങ്ങൾ നമുക്ക് പഠിക്കുവാനായിട്ട് സാധിക്കട്ടെ. അറിവിൻ്റെ തലത്തിലേക്ക് അങ്ങനെ ഒത്തിരി പേരെ ജീവനിലേക്ക് കൈപിടിച്ച് നടത്തുന്നവരായിട്ട് മാറുവാനായിട്ട് സാധിക്കട്ടെ. ബിക്കോസ് നിങ്ങളാണ് ഇൻസ്ട്രുമെൻ്റ് ഓഫ് ഗോഡ്, ദൈവത്തിൻ്റെ പ്രതിരൂപങ്ങളായിട്ട് മാറുന്നവരാണ് നിങ്ങൾ ഓരോരുത്തരും. അപ്പോൾ എല്ലാവിധ ആശംസകളും സ്നേഹത്തോടു കൂടി നേരുന്നു. നന്ദി.
Thank you, Acha. Before we move on, as a gesture of heartfelt appreciation and remembrance of this occasion, we are honored to present mementos to our distinguished delegates. May I invite Father Joyce Nandikunnayal to give away the memento. First, can we have Dr. Arunalok Chakrabarti to kindly come forward to receive the memento. Now, let me invite Dr. Rajiv Soman to come forward and receive the memento. May I invite Dr. Sajid Kumar to the stage to accept this token of appreciation. Up next, let me invite Dr. Parishit Prayak to come forward and receive the memento. Now, I kindly welcome Dr. Praveen Kumar Trilangi to come forward to receive the memento. Now, I kindly request Dr. Gidu Jo to come forward to receive the memento. I request everyone to kindly come forward to take a group photo.
We now move on to the next session on optimizing antimicrobial therapy in the ICU, PKPD, therapeutic drug monitoring, and precision dosing in critical illness by Dr. Parishit. Sir, we are extremely sorry for the inconvenience caused before.
Yes. So, good morning once again, and thank you for inviting me to this lovely meeting. Like I mentioned some time back, we came here last year for the FISF course, and the hospitality is lovely. The state is, needless to say, one of the most beautiful that I've seen in India. So, we are going to be talking about PKPD and TDM of antibacterials. And as Praveen mentioned in the morning, like he did, we'll go slow with this because there is a lot of mathematics in this. There are some things to be understood, digested, the kind of levels that we've been doing, and how do we apply all this in terms of this PKPD knowledge at the bedside. So I'll be talking about some of the most important drugs that we use in the ICU settings. We'll start with the gram-positive drugs and then move on to some of the drugs that we use for our gram-negative infections. So throughout this talk, we'll be using some illustrative cases to demonstrate, how the levels help us in clinical practice and how we can sort of adjust our antimicrobial therapy based on these levels. So let us start with a drug like vancomycin. Now we all know that any antimicrobial that we use, the important aspect there is to optimize the pharmacodynamics. So if you talk about antimicrobials, I'm sure you must have heard these. Thank you. I'm sure you must have heard these terms. AUC by MIC or peak level to the MIC ratio or time spent above MIC. So any antibiotic or any antimicrobial that we use in the world of infectious diseases, the first important question is that, which is the pharmacodynamic parameter that we are using for this particular drug. What are the data which have been published regarding, how to optimize that pharmacodynamic target, and then trying to see, if therapeutic drug monitoring can help us at the bedside. There are several other things to be considered. So you want to know the pharmacokinetics, how bound is the drug, what is the albumin level in your patient, what is the volume of distribution, because in critically ill patients, all these things change. So we'll see this with the help of a few cases. So let us look at our first patient here. This was actually a surgical resident from the Government Medical College in Nagpur who was found to be dengue positive, had thrombocytopenia. No HLH markers were done. There was no one like Praveen to interpret those things also at that place probably. But there were no HLH markers done at that time. And then he was started on DEXA. After a week of DEXA, his platelets, not surprisingly, and I wouldn't say because of DEXA, but were 1,50,000. So let's leave aside the need for DEXA. But after a week of that, he developed bilateral lower extremity pain, and MRI showed multiple collections. So there was a collection in the right obturator, iliacus, head of gastrocnemius, and blood cultures grew MRSA. Vancomycin, the MIC was 1, and he was started on vancomycin 1 gram BD. The transthoracic echo showed no vegetation. Most important thing, as you will all agree with me in this type of a patient, is source control. So, irrespective of what we do at the bedside, source control is going to be important. But despite being a surgical resident, or maybe because he was a surgical resident, he refused to go to the OT and he refused source control. So, day 5 of vancomycin, he still remained febrile. At that point of time, the treating team got a vancomycin trough level which was 7. Now, as you would all know that this trough level is a little lower than what you want the trough level to be. But how do we put this all together? So vancomycin, so for most drugs, if not all, a commonly used pharmacodynamic index or parameter is the AUC to MIC. So what is that? It is the area under the curve. So ideally, if you send drug levels every hour and you plot a graph, then the area that you will get under that curve will be known as the 24-hour AUC of that drug. Now, that is easier said than done, right? In clinical practice, of course, we don't send hourly levels. And then if you divide this by the MIC, you get the ratio something known as AUC by MIC. Now here you know that the MIC of this particular isolate MRSA is 1 for vancomycin. Now what has literature shown that AUC MIC ratio of above 400 is a good target for vancomycin. So let's use this simple piece of information for our case, that the AUC MIC ratio for vancomycin you want it to be above 400. So let us see if this is as simple as this statement sounds. So this is a study which showed that an AUC MIC of more than 400 predicts the efficacy of vancomycin the best. So many years back, about 15-16 years back, trough concentrations were the only drug levels recommended for vancomycin, and at that time the guidelines suggested, or they weren't really guidelines but consensus recommendations suggested that troughs of 15 to 20 are recommended. So troughs of 5 to 10 are subtherapeutic, troughs of 10 to 15 are slightly subtherapeutic depending on what and where you are treating, whereas in the site of infection, whereas troughs of 15 to 20 are recommended. And if you keep troughs between 15 and 20 for most of your patients, you will be able to achieve an AUC MIC of more than 400, provided the MIC is up to 1. If the MIC starts going above that, then even with troughs of 15 to 20, it's going to be a problem. But then in the next 7, 8, 10 years or so, there was a significant amount of literature published which showed that just doing this based on troughs might actually be overestimating the AUCs that we actually need. What does that mean? That AUCs are the actual drivers of nephrotoxicity as far as vancomycin is concerned. So when I'm trying to optimize the pharmacodynamics for my patient, what I want to do is that I want to optimize the efficacy, and I also want to optimize the safety of these patients. So if you look at the AUCs, when you keep troughs between 15 and 20, often you generate very high AUCs. So often you will end up generating AUCs like 600, 800 and so on. So that's why just basing this on troughs might actually be giving you very high AUCs, and that might be subjecting the patient to nephrotoxicity. So AUC control of vancomycin therapy. So literature suggested that it is better to do this based on AUCs rather than trough values alone, because just trough values alone might needlessly be giving you high AUCs. And then this was this wonderful paper which was published by Tom Lodis in 2020. And what he did was that he divided these patients into different quintiles, and what he showed was that look at the second quintile there and look at the purple part of that figure. So what it shows is survival with therapeutic success and no AKI. So that is what I want for my patients. I want my patients to survive without nephrotoxicity. Survival with nephrotoxicity or no survival, of course, are not good endpoints. So what I want my patients to do is survive without having nephrotoxicity. And the bottom quintile had very few patients, but if you see the second quintile there, then the AUCs there are between 389 to 515. So let's say between 400 and 500. So those patients in whom the AUCs were between 400 and 500, just the AUCs, actually did the best and also survived the best in terms of nephrotoxicity. So they did the best in terms of efficacy as well as safety. So 400 to 600, often when your AUCs start exceeding 500 or especially 600, you start entering into the zone of nephrotoxicity. So that's why AUCs between 400 and 500 might be good AUCs to generate as far as vancomycin is concerned. And that's why in 2020, the consensus statement was revised, in which they said that in patients with MRSA, an individualized AUC to MIC of 400 to 600 should be advocated, but the preferred approach to do this is to compute the AUCs rather than just looking at the trough values alone. Now the question is, how do we use or how do we compute AUCs at the bedside? There are two ways of doing this. One is that softwares which use both trough and peak levels, which means that you get a trough level for your patient, you get a peak level, which is something which I'll show you, get a trough level and get a peak level, and then allow the softwares to compute your AUCs. The second method is if you are doing it just based on trough levels, then you will be using a lot of population pharmacokinetic data to compute the AUCs. What does that mean? That you are giving that software just a single time point. So you're just giving him one level of the patient's vancomycin level, and you're using or extrapolating population pharmacokinetics to do this. So in stable patients, this might be sufficient, but in patients in whom we expect the pharmacokinetics to be different from the median population pharmacokinetics, there might be a problem. So our critically ill patients who have altered volume of distribution, drugs which have very high protein binding, you cannot extrapolate this data from the population pharmacokinetics. So trough only monitoring is no longer recommended. So back to our case, peak levels were done and peak levels were actually 15.4. So this is an example of a software that uses both the trough levels and peak levels, and you can see that it asks you different questions, that how much are you giving in terms of the dose, when are you giving this, what is the duration of infusion, and how many levels have you measured. And it is also checking that the timing is right, that you have sort of measured them at the correct time intervals, that peak levels have been drawn 30 to 60 minutes after the dose has ended, and trough levels have been drawn 30 to 60 minutes before the dose has started. So once you have done all that, then it is computing and saying that right now for my patient here, the AUC is around 266. Now my MIC is 1, right? So I have an AUC MIC ratio of around 250 or 260 for this patient, which is slightly inadequate. Now that's not to say that that's the only reason why he's spiking. Of course, like I said, there are lots of other things that need to be done, including source control, making sure that, you know, we have sent repeat cultures, thinking of TE if those cultures are positive and so on, considering combination therapy. There are lots of aspects to it, and MRSA is going to be covered later in the afternoon, but just focusing on the AUCs here. Then it also tells me what a good new dose is, and look at the predicted AUC with that new dose. The predicted AUC is 466. So that's a good AUC. And this is one of the ways in which these calculators can be used, because like we saw from Tom Lodis' study, we don't want to exceed the AUCs, because AUCs of more than 600 often start becoming nephrotoxic. What it also means is that if I have, let's say, an MIC of 2, these things are very, very difficult to optimize, because the moment you have an MIC of 2, here the AUC that you need for success is actually going to be around 600 to 800, or at least 800, and that is again going to be in the nephrotoxic range. So what it tells me is that in sick patients, you know, using trough and peak levels can be useful, and AUC is a better measure or a better predictor of toxicity than trough levels alone. And it also tells me that I can sort of dose modify, and it also tells me that the moment you start going above an MIC of 1 for vancomycin, it becomes a problem. Add to that some of the pharmacokinetic constraints that we might have with vancomycin. Protein binding is not very high, so that problem we'll see next when we talk about teicoplanin. So protein binding is about 50%. CSF penetration is a big spectrum. So if you look at studies with very highly inflamed meninges, then the CSF penetration is going to be better. But giving steroids or blunting the inflammatory response is a big problem, and that's why if you look at something like refractory or resistant streptococcal CNS infections, then vanco plus dexa is not recommended, because the moment you give dexa, the inflammatory response is going to be on the lower side and the vanco penetration can suffer. So vanco penetration, and that's not, you know, something which is exclusive to vancomycin, but vanco penetration does suffer from is dependent largely on the meningeal inflammation. ECMO, there is minimal impact on the drug pharmacokinetics, but most of the literature has looked into levels as well. And dosing in the OBs is they are advocating using actual body weight, but not to exceed a maximum dose of 3 grams. So these are the kind of situations in which drug levels become even more useful. So drugs which are weight based or dosing is based on the weight. So we'll come to that when we look at drugs like polymyxin, daptomycin, and so on. So with this, let's move to our second drug, something that we use very commonly in our ICUs, teicoplanin. So teicoplanin is just about beginning the journey that vancomycin started about 10 years back. So right now, most of the teicoplanin recommendations are still based on the trough levels rather than looking at computing AUCs. Now, teicoplanin is also limited by the fact that it's not available in the US, or not a lot of data is generated from there. But if you look at AUCs again, then studies have shown that AUCs of around 600 to 800 are good predictors of clinical success. So should we do therapeutic drug monitoring? This meta-analysis in 2021 showed that trough levels of 15 to 30 were associated with better clinical outcomes than trough levels of less than 15. The great part about teicoplanin is that your toxicity levels or thresholds for toxicity are very, very high. And this is typically a drug wherein the safety margin is very high. So if we have residents here, safety margin is the difference between what is an effective level and what is a toxic level. And that difference is very, very high for a drug like teicoplanin. We'll see exactly the opposite case when you look at colistin. What is a good level is also a toxic level for colistin. But if you look at a drug like teicoplanin, then thrombocytopenia, the risk starts above a trough level of 40, whereas nephrotoxicity, the risk starts above a level of 60. So that's why you have a lot of room to err on the side of caution as well as teicoplanin dosing is concerned. So one way of doing this is level guided. The other way of doing it is making sure that we are really giving good doses to our patients rather than the 6 milligrams per kg BD doses that are commonly used in the ICUs. And teicoplanin is very, very highly protein bound. More than 90% of teicoplanin is protein bound, so that can be a problem. So whenever a drug has very high protein binding, and if you have a patient who is hypoalbuminemic, it is a double-edged sword. So it is sort of a paradoxical situation, because what you might think is that the unbound part or the free drug concentration can increase, but it can also mean that the renal clearance is accelerated in these type of patients. So that's why it sort of becomes unpredictable to predict the total drug levels in these type of patients. So that's why hypoalbuminemia can be a double-edged sword. For the most part, you will see that TDM is recommended for these type of patients. So patients with serious infections, wherein the levels recommended are about 20 to 40, or those with acute or chronic renal dysfunction, obesity, because again, you will often use doses which are 6 to 12 milligrams per kg in burns and hypoalbuminemic patients, because there the clearance may be accelerated, pediatric populations, and of course patients who respond poorly to teicoplanin. So teicoplanin levels are mainly done to augment the efficacy of teicoplanin, really not to minimize the toxicity. So whenever we are doing any therapeutic drug monitoring, the goal has to be fairly clear, that are we doing this therapeutic drug monitoring to look at efficacy or toxicity, and in some cases it might be for both, but in cases of teicoplanin it is mainly done to look at the efficacy. So if you want to generate levels of 15 to 30 or 20 to 40 for serious infections, these are the kind of dosing schedules that are recommended. So look at those schedules. Those are higher than what are commonly used in many patients in our ICU setting. So 10 milligrams per kg twice daily on the first and second day, and then third day onwards 10 milligrams per kg, or even 12 milligrams per kg twice daily, then once daily on the third day, and then going to your maintenance dose of about 6 to 6.7. Again, this largely depends on what you're treating. If you're treating a bone and joint infection, or if you're treating a serious bloodstream infection, these numbers are again going to vary. But for the most part, in those type of serious infections, you would aim for levels, trough levels between 20 and 40. So this data is probably 3 or 4 months old now. So we have done teicoplanin levels in almost 25 patients in our hospital. The median levels are fairly good, but number of patients with levels below 15 were 8, and number of patients with levels below 10 were 3. So I think those are good numbers, because see, if you have a hypoalbuminemic patient, what can happen is that you may want to aim for slightly lower total drug levels. The assays that we do in our labs, they measure the total drugs. They usually don't do ultrafiltration, so we don't get the free drug levels in the assays that we do in our lab. So what we are essentially measuring is total drug level of teicoplanin. Now, if you have a patient who is really very hypoalbuminemic, then the free drug is often going to remain, or the unbound component is often going to remain same, whereas the bound component is going to shrink. So that's why, so there are nomograms which are now published, which show that if you have really low albumin levels, you may aim for something like 10 to 15 in really hypoalbuminemic patients. Whereas if you have normal albumin levels of about 3, then you want to aim what we looked at, 15 to 30 in non-serious infections and 20 to 40 in serious infections. But below 10 is concerning for any patient, is what I would think. So 3 out of 18, so 1/6 of the patients did have really low teicoplanin levels, and number of patients in whom the teicoplanin dose was changed when the results were available was 7. And these are essentially patients in whom, or in all of them, the dose of 6 milligrams per kg BD has been used. So it really goes on to show that the normal dose that we use of 6 milligrams per kg BD for 3 doses and then 6 milligrams per kg OD may not be sufficient. Add to this the fact that patients in the ICU who are in sepsis or in septic shock, there are many pharmacokinetic constraints. So like I said, there are pharmacokinetic constraints with teicoplanin. It's a highly protein bound drug. 90 to 95% of the drug is protein bound. Like I said, high protein binding and patient with hypoalbuminemia can be a tricky situation. While you might think that you're going to get a lot of good free drug there, it's also going to mean that the excretion is going to be high, especially when the volume of distribution is altered in sepsis. The clearance is also going to be increased. CSF penetration is negligible, and ECMO increased dosing may be needed, but again, most of the ECMO literature also looks at therapeutic drug monitoring, and dosing in obese is actual body weight. But again, I think the best safeguard that we have in these two situations, ECMO and obesity is therapeutic drug monitoring. Let's look at linezolid. So linezolid is a drug such that we have been now increasingly using therapeutic drug monitoring for linezolid in our hospital. So let us look at some of the parameters of linezolid. Again, if you look at AUC-MIC ratios, again it's a drug that for which you will mainly look at AUC-MIC ratios. Now here you want an AUC-MIC of more than 100. At the same time, the literature is saying that if you exceed AUCs of 300 or 400, you are invariably likely to hit hematological toxicity. So thrombocytopenia, so peripheral neuropathy is not so closely linked with the AUCs, but if you look at thrombocytopenia or if you look at myelotoxicity, then it is very, very closely linked to the AUCs. So if you have AUCs which exceed 300 or 400, then you are going to, it is very likely that you will enter into the zone of myelotoxicity, which itself tells me that the moment my MIC goes above 2, it's not a great situation to use linezolid. So let's say I have a patient who has an MIC of 4. So you are treating an enterococcus which is resistant to everything else. The linezolid MIC is 4 and you are using linezolid. Now for me to generate a good AUC MIC, so which means that if I want to generate an AUC MIC of above 100, I have to generate an AUC of above 400 for an MIC of 4. And that is when you will enter the zone of hematological toxicity. So with linezolid, the moment the MIC is above 2, it becomes very difficult to have both efficacy as well as toxicity. And look at these studies which show that for what levels, what kind of AUCs are generated, or the probability of achieving different AUCs. So let's look at a level of 2 to 5. I am guaranteed to generate an AUC of more than 100 for any of these levels, but 200 and 400 become difficult. So now let's take two separate patients, one in whom the MIC is 1, and or let's take two different isolates, one isolate for which the MIC is 1 and one isolate for which the MIC is 4. The first patient is much better off because you have an MIC of 1 there. I can keep levels around 5, which will give me AUCs of around 100, and I can also have a good AUC-MIC ratio, and I can also stay away from the hematological toxicity. The hematological toxicity in terms of trough levels starts increasing as the levels exceed 7. About 10, almost 100% chance, more than 80% chance that your patient is going to have myelosuppression. Whereas if I have a patient whose MIC is 4, I would want to generate high AUCs. Even with 8 to 11, it might be difficult to generate those kind of AUCs. And with 8 to 11, I am guaranteed to get myelotoxicity. So that means that those are actually situations in which I am buying toxicity and not even ensuring efficacy. So these are very, very difficult situations for using linezolid. So that's why linezolid, if you look at the evidence, most of the evidence is in terms of minimizing the toxicity. Trough concentrations of around 2 to 8 have been recommended, and again linezolid TDMs for whom I think TDM is something that can be useful in any patient, although in terms of the finances and the constraints and the resources, you would want to select out patients in whom you would want to do a TDM. So let's look at this patient we recently had. This is a 43-year-old male, 4 weeks post a living donor liver transplant. He developed fever, blood cultures grew ephesium, which was resistant to vancomycin, ampicillin, tigecycline, teicoplanin, sensitive to linezolid. The daptomycin MIC was also high, and the platelet count was 88,000 with mild transaminitis. 4 weeks post transplant was started on linezolid. Trough levels were obtained on day 4, and the trough levels were 14. So again, this is a patient, the linezolid MIC was 2. So this is a patient in whom it is going to be slightly tricky, because while I want AUCs of about 200, I really don't want these kind of trough levels for my patient. And these are the recommendations for dose adjustment. So again, I'll be happy to share these slides with you, because this is not something that we need to learn by heart, but we just need to keep in mind that these sort of resources are available for our patients at the bedside. So there are recommendations to decrease or increase the linezolid doses depending on what trough levels you are getting. So this can be a good adjunctive tool, and especially in patients in whom you are constrained. So that's the only drug which may be working in these type of patients. It might be a useful thing to do. Again, protein binding is not very high. It's a drug that has good CSF penetration. ECMO increased dosing may be required. So TDS regimens have been recommended, but again, those are good patients to do therapeutic drug monitoring on. Dosing in obese, standard dosing may be inadequate again. So again, these are two sets of patients in whom you might want to consider higher doses, but look at the overall picture. So if I have a very, very low MIC, I wouldn't really want to push for these kind of high doses and invite toxicity, because MICs of less than 1, we are happy keeping the levels between 2 and 5. And it's a drug that has excellent pulmonary penetration. So it's a very, very good drug for pulmonary infections and has very high oral bioavailability. Let's look at the last drug in our gram positive section. So we're going to be talking about daptomycin. So daptomycin is again an interesting drug. We'll talk a little bit more about this when I'm going to be talking about enterococcal infections later in the day. But if you look at enterococcal infections, then again, the probability of target attainment really depends on the MIC and what dose you're using. So let us try to, sorry, I don't think this is working. Yeah. Okay. Sorry, I'll just use this. I'll just use. So if you look at this figure here, then look at the probability of target attainment for different doses. So there you have daptomycin 6, 8, 10 and 12. And what is the target? You want a free drug AUC MIC of, let's say, more than 27. So you want a good AUC MIC for daptomycin. Look at what happens when you have an enterococcal isolate which has an MIC of 0.5. Pretty much any dose that you give, you are very highly likely to meet your pharmacodynamic target. What happens when you have an MIC of 1? Again, very high chances, 90% or more, that for most doses that you give, even for 6 milligram per kg, there is almost a 90% chance that you will meet your pharmacodynamic target. But look what happens when you have an MIC of 2. When you have an MIC of 2, if you give this patient 6 milligrams per kg, you have a less than 40% chance of meeting your pharmacodynamic target. And if you have an MIC of 4, and if you give this patient 6 milligrams per kg of daptomycin, you almost have a 0% chance of meeting your pharmacodynamic target. And as I'll show you later in the afternoon, the success of daptomycin depends largely on the doses that are used. So anytime you have more than one, I would say, so 2 or more as the MIC of the enterococcal isolate, then higher doses are recommended. Similarly for MRSA, so if you look at this figure, similarly for MRSA, look at the different scenarios. So they are based on the creatinine clearance. So let's look at the bottom figure first, scenario C, which is normal GFR. So if you have normal GFRs up to an MIC of 0.5, pretty much all doses you are very highly likely to attain your pharmacodynamic targets. Whenever the MIC exceeds 0.5, whenever the MIC becomes 1, then for most doses, your chances of actually attaining the pharmacodynamic target are not that bright. So how does this translate into clinical practice? Of course, daptomycin TDMs are not standardized at this point of time because there is conflicting data on the applicability of these TDMs. But how does this translate into clinical practice? That let's say you are treating an enterococcus and you have an MIC of 2 or more, you would definitely use higher doses. Now there are nomograms also which look at the GFRs and give you doses of daptomycin. And if you have MRSA and you have an MRSA MIC which is exceeding 0.5, then your again chances of therapeutic failure are pretty high with daptomycin. So let's say I'm treating an MRSA with an MIC of 1 and I'm not left with any other option, which rarely happens for MRSA, but then daptomycin monotherapy is not going to be the ideal answer to this kind of a patient. So what are good MICs for MRSA? Based on all the discussion that we have been having, if you exceed an MIC of 1, that's not a great situation for vancomycin, because as we discussed earlier, you will have to have very high AUCs. If you have an isolate of MRSA which has a daptomycin MIC of more than 0.5, again pharmacodynamically it's not a great situation. And if you have an isolate of MRSA which has a teicoplanin MIC of more than 2, again it's not a very good situation, because like we said, we want to have AUCs between 600 and 800. So if the MIC now creeps up above 2, it becomes very, very difficult to optimize the teicoplanin AUC MIC. So this is how it would translate into clinical practice. So there are again two ways of doing this: either access to TDMs in terms of teicoplanin or vancomycin, or very carefully, or even doing both, very carefully looking at the MICs and looking at the kind of dosing regimens that we are using for our patients. Now, this is the daptomycin TDM data. So the daptomycin TDM data is not very robust at this point of time. So if you look at I have compiled all the studies which have looked into daptomycin TDMs, and they are not really giving us any uniform conclusion. So this first study, there was a large individual variability in serum levels. A trough level less than 3 was independently related to a poor outcome. So they did talk a little bit about efficacy. But the next study, this was a systematic review and identified no published studies comparing the clinical outcomes of patients who had daptomycin TDM with subsequent dose adjustment with the outcomes of those who did not have TDMs done for them. And even for toxicity, there are conflicting data. So the first study there shows that the trough level was significantly associated with CPK elevation. And the next study shows that trough concentrations more than 24 were associated with an increased probability of CPK. And the third study shows no significant relationship. So again, the thresholds are different in different studies, and we don't even know whether it really tightly correlates with CPK elevation. So both in terms of efficacy as well as in terms of toxicity, daptomycin TDMs is not the standard of care at this point of time. If you look at drugs like linezolid or teicoplanin or vancomycin, then the utility of TDMs is far more established. So for daptomycin, still have to go back, find out the MICs, look at whether you're dosing this patient properly, look at the GFRs. That's not to say that you won't be doing it for the other drugs, but for daptomycin, this is all that we have. Again, a fairly protein-bound drug. CSF penetration is not great. ECMO, minimal impact on drug PK, but like we said, there are many other aspects to dosing daptomycin than just whether the patient is on ECMO or not. We all know that it is inactivated by the pulmonary surfactant, but it does penetrate into the pleural fluid. So recently we had a patient who had a really bad enterococcus, and we used daptomycin. I mean, the patient had multiple other issues and finally didn't make it. But the point is that it does penetrate into the pleural fluid, although the pulmonary surfactant would destroy. What about aminoglycosides, and how can we optimize TDMs for aminoglycosides? Now, unlike the 4 drugs that we saw till now, in whom we used AUC by MIC, aminoglycosides are a little different because we use something like a peak concentration to MIC ratio. So the moment you give aminoglycosides, if you get a peak level done and that peak level exceeds your MIC tenfold, then you have a very good chance of therapeutic success. But you can't just have one on your wish list. So I can't say that I want very high peak levels, but I want very low trough levels. Inadvertently or invariably, they will go hand in hand. So that means that the threshold for toxicity is important. So threshold for toxicity starts above a level of something like 5 for amikacin and 1 for gentamicin. So let us look at this case that we had recently, or maybe last year. This was a patient with Evans syndrome. So cytopenias, autoimmune cytopenias, hemoglobin is 6.7, thrombocytopenia, and it is shown 6/6, but eventually she had, I think, 8 or 10 bottles which actually grew nocardia and had endocarditis. And look at the MICs for nocardia there. You don't have a lot of good options. The QT was 676. So that's why a lot of those options are poor options for her. So if you look at this patient, and if you look at the options for nocardia, endocarditis, we don't have a lot of options. We have amikacin there, we have fluoroquinolones, but with a very high QT, and then you have linezolid, which is sensitive. So we don't have a lot of options. And again, this is a patient who has cytopenia. So this is a patient in whom I don't want to lose my aminoglycosides for toxicity. So the peak level was 28.6. The MIC for amikacin is 1. The peak level was 28.6, and the trough level was 15. So definitely this is a patient in whom you can reduce the amikacin dosing, because here you are basically doing your TDMs to look at the safety of amikacin, because that's something that you don't want to let go of, because Bactrim, fluoroquinolones, all these are not great options. Linezolid, all these are not great options for her if you look at the toxicity of these drugs. And then polymyxins. So let's look at the PKPD constraints of polymyxins. So this is something that is very important. These are drugs that we use so commonly in our ICUs. So let us try and understand some fundamental differences between polymyxin B and polymyxin E, which is colistin. The first important difference is that colistin is administered as a prodrug. So you administer CMS, which is a prodrug of colistin, and that is the drug that really penetrates into the GU tract and has renal clearance. So then it is converted to colistin, which actually does not have a lot of renal clearance, and that's why we say that for GU infections, colistin is better than polymyxins, because polymyxin has non-renal clearance. So that is a very, very important difference. The other difference is that polymyxin is not administered as a prodrug. So these are two fundamental differences between colistin and polymyxin, that colistin is administered as a prodrug and polymyxin does not have any renal clearance. So what does it mean in clinical practice? So CMS is eliminated predominantly by the kidneys. Colistin is mainly cleared by a route other than renal excretion. So what happens is that following parenteral administration of CMS, colistin is formed slowly. So this can partly be overcome by giving a patient a loading dose of colistin. Whereas what happens is that since the prodrug is renally excreted, when patients have different creatinines, the impact of that creatinine on colistin levels can be very, very significant. So look at this study here. I'm sure you must have seen this study in a lot of other presentations. So whenever patients have normal GFRs, so look at those patients who had GFRs of more than 80, the colistin levels were very, very poor. So very few patients actually had levels of around 2, which are good levels for colistin. So that's why it is difficult to get good colistin levels in patients who have a normal or augmented GFR. And if patients have poor GFRs, then colistin is a dangerous drug to use to begin with. So that's why there are problems with using polymyxins. Whereas polymyxin B is mainly eliminated by non-renal pathways, and renal function does not markedly affect the polymyxin plasma concentration. Now, what about the pharmacodynamic targets for polymyxins? So if you look at polymyxins again, the parameter that we are looking at is something known as an AUC-MIC ratio. So AUC-MIC ratio is what you're looking at. So this is data from a couple of studies, mainly animal models. And again, I'll sum up this slide for you. What it really means is that your AUC-MICs that you require, the targets, now whether we are attaining that is a completely different story, but even the targets to begin with are extremely high for Klebsiella and for pulmonary infections. In fact, you will see that a 2-log kill wasn't achieved for many of these situations. So look at Klebsiella, a thigh infection model, 2-log kill was not achieved for any strain. Klebsiella pulmonary, it is difficult to even achieve stasis. And Acinetobacter and Pseudomonas pulmonary, again, very, very difficult to achieve a 2-log kill. So Acinetobacter, it was not possible to achieve stasis for 2 out of the 3 tested strains. So what it means is that if you have pulmonary infections or if you have Klebsiella, you really need to generate very, very high AUCs to, and even then you may not be able to achieve sidality. Whereas if you have, let's say, a bloodstream infection with an Acinetobacter, that might be slightly more of a forgiving situation in terms of the pharmacodynamic targets. And that's one of the reasons why the nomenclature of polymyxin sensitive has been abolished. So polymyxin is either now labeled as intermediate or resistant. And one of the major parts of that is that with monotherapy, for most of the situations that we use it for, the pharmacodynamic targets are very, very difficult to achieve. So the international consensus guidelines, what levels do they recommend? They say that the target AUCs should be around 50, which translates to trough levels of around 2 for colistin. The problem with colistin is that what is, like I said in the beginning of my talk, what is a good level is also a toxic level. So the toxicity starts about 2.5 trough levels, and the good levels are around 2. So what is a good level is also what is a toxic level. So classically, it's a drug which has a very, very narrow safety window. For polymyxins, you have a little bit more breathing space because toxicity usually will start above AUCs of 100. So keeping AUCs around 50 to 100 might be a good strategy, or in other words, keeping troughs between 2 and 4 might be a good strategy. But again, these are very, very difficult compounds to handle in the lab. Just like we struggle to get good MICs for these compounds, therapeutic drug monitoring is also very, very difficult. So the international consensus guidelines say that we do recommend TDMs, but access to TDMs challenges, especially for colistin, is very, very difficult. So in our hospital, we do polymyxin B levels. So again, if you look at our last 20 patients, the median levels of poly B have been quite good. Number of patients in whom the level was more than 4.3 and number of patients in whom the level was less than 2 was about 5. But it still means that in 8 out of these 20 patients, you would still adjust the polymyxin dose. So it's a good adjunctive tool to have. But having TDMs, again, I can tell you from my experience that having TDMs doesn't bypass many of the problems that we have with polymyxin still, which means, and what are those? Those are very, very poor pharmacodynamics in the lungs, even for Klebsiella, even for non-pulmonary infections, achieving sidality and having narrow margins of safety. So, and again have difficulty in actually measuring the cholesterol level. So that's why it's a difficult thing to do. ECMO, again TDM is recommended, although they say that there is minimal impact on the drug pharmacokinetics. And in the obese, since we usually use weight for dosing polymyxin, use adjusted body weight for polymyxin B, but they say that consider limiting the maximum daily dose to about 25 lakh units. So 25 to 30 is the maximum dose that you can push, which means about 12.5 to 15 lakh units BD in obese patients. Of course, if you have TDMs, then you would want to do TDMs in obese patients to make sure that you are not exceeding a level of 4 for polymyxin B. Like I said, you have a little bit more breathing space when it comes to polymyxin B versus cholesterol. And we all know that renal adjustment is required for cholesterol. Now, changing gears, let's look a little bit at beta-lactam antibiotics. So far, we've been looking at drugs for which we have used levels, either the AUC to MIC ratios, or we have looked at the peak concentration to MIC ratios, unlike beta-lactams. So for beta-lactams, as you all know, most of the data will point towards the time which is spent above MIC. So if you spend at least half of the time above MIC, that's a decent target. If you spend all the time above MIC, that's an even better target. If you spend all your time above 4 times the MIC, that's a very, very aggressive pharmacodynamic target for many of the beta-lactams. But then in doing that, we must also keep in mind the toxicity thresholds. So look at the neurotoxicity thresholds. The neurotoxicity thresholds are fairly high, but look at cefepime. It's a drug that has a fairly low neurotoxicity threshold, and that's why you will see some patients, especially who have impaired GFRs, having neurotoxicities with cefepime. But in general, what we do is look at optimizing the time above the MIC. So is TDM useful? Now TDM can be useful in some patients in whom we have constraints, but in general, if you look at data, so if you look at this study as well as this dolphin trial, they showed that routinely doing TDMs for patients in whom you are using beta-lactams may not be that useful. But definitely there are patients in whom, selecting out TDMs is important. So again, the list is sort of intuitive or predictable. Critically ill or augmented renal clearance, ECMO, CRRT, special populations, suspected toxicity, especially for drugs like cefepime and so on, TDMs can be useful. This takes us to an important concept of optimizing the pharmacodynamics for beta-lactamase inhibitors. So while we talk about beta-lactams, it's also important to optimize the pharmacodynamics for beta-lactamase inhibitors, so our clavulanate, sulbactam, avibactam, tazobactam, and so on. So how do we look at this? So just like we have time above the MIC for beta-lactam antibiotics, we have something known as a threshold concentration for BLIs. So what is a threshold concentration? A threshold concentration is the minimum amount of the BLI. Remember, we are not talking about the beta-lactam here. We are talking about the beta-lactamase inhibitor. So the minimum amount of a BLI which is required to inhibit the target beta-lactamase and restore the beta-lactam activity. So this is specific for specific beta-lactam. So for example, if I talk about ceftazidime avibactam, then the CT or the threshold concentration is the concentration of avibactam that I need to protect the ceftazidime against a particular enzyme. So something maybe like a KPC or an OXA48. Whereas if I talk of something like aztreonam avibactam, the CT or the threshold concentration of avibactam is the concentration which is required to protect the aztreonam. So remember, initially when ceftazidime avibactam was formulated, the threshold concentrations took into account protection of ceftazidime, not the protection of aztreonam, because originally it was meant to be a drug which was used for KPC producers or OXA48 producers. Then later on, there was this addition of aztreonam for NDM producers, and then we've had all this data and we've been using it in combination for NDM producers. But the original CT studies were done for protecting ceftazidime against KPCs or OXA48, and that is where it is different. So that's where we come to aztreonam avibactam. So as you all know now, aztreonam avibactam is available. So if you look at the ratio of the beta-lactam to the beta-lactamase inhibitor, it's a little bit different. So normally what we were doing was giving, let's say, 2000 milligrams of ceftazidime and 500 milligrams of avibactam with 2 grams of aztreonam. So for every infusion, we were giving a ratio of 4:1 for aztreonam avibactam. So if you look at the threshold concentration, and if you look at optimizing both the aztreonam pharmacodynamics as well as the avibactam pharmacodynamics, then aztreonam avibactam has a ratio of 3:1. So if you look at Astronom avibactam, it has a ratio of 3:1, and these are the doses. These are the dosing recommendations for Astronom avibactam. So you can see there that the loading dose, which has been talked about quite a bit, that is a bit of a problem, because you have 2 grams and 0.67 grams of Astronom avibactam, which means that you have to give a vial and open another 1/3 vial. Recently, there has been a study which has looked into this and shown that there is not much of a difference even if you don't open an additional vial, but that's just one study out there. But the dosing recommendations or the manufacturer's recommendations are still to give 1 vial and 1/3 of a vial, and then give the subsequent doses every 6 hourly. So again, this can become a little bit of an issue in our settings. In the last 10 minutes, let's look at some of the other drugs. So let's look at a very interesting case. A 30-year-old male with AML post induction therapy developed fever. He was neutropenic, being treated for AML with induction therapy. Blood cultures were sent. He was started on piperacillin tazobactam. The procal was 11.4 and the creatinine was 0.6. Next day, the lab called and said that there is GNB in the blood. A PCR-based test was done. It showed E. coli with SHV, CTXM, and NDM. So was started on ceftazidime avibactam plus Astonam, and this was his susceptibility report. As expected, NDM was there, so Cazavi was resistant. Astonam was resistant because he also had CTXM there. Now the Cazavi plus Astonam synergy was not detected, and the colistin manual MIC was between 1 and 2, and phosphomycin MIC was 32. So now this brings us to the pharmacodynamics of phosphomycin. So this is likely a mutated PBP3 or PBP3 with inserts, because you have other enzymes there, NDM, CTXM, maybe CMY, and you have a PBP insert there, which is making the combination of Cazavi plus Astonam resistant. So our options are limited for this type of a patient. We might have cefepime zidibactam. We might want to test for plasmomycin, but again, there is NDM there. So you don't know which type of resistance is there for plasmomycin. But again, I'm not going to go into the details of that. But what we have here is that a patient in whom it is important to use phosphomycin well, because this is a patient who has an augmented renal clearance and also has a phosphomycin MIC of 32, and a drug that is important in this type of a setting when Cazavi plus Astonam synergy is failing. So again, this takes us to the concept that optimizing doses in some patients is extremely important. Whereas if you have a lot of luxuries, you might be able to get away without even optimizing pharmacodynamics for some of your patients. So let's look at when you have an MIC of 8, regardless of the dose that you will give this patient. If you give even an 8 to 12 grams daily dose of phosphomycin, you will be in the green zone. So more than 90% chance that you are attaining your pharmacodynamic target. Whereas look at an MIC of 16. If you have an MIC of 16 and if you have an augmented clearance, then you are not going to get away with a dose of something like 8. But again, if you give a dose of 12 grams per day, you will be good in most of the patients. But now I have a patient who has an MIC of 32 and has a GFR which is around 150. So now that is a problem, because if I give him a total dose of 12, so 4 grams TDS of phosphomycin, I might be in the yellow or even in the red zone for a GFR of 150 or above. So that's why, and then these are the recommendations for augmented clearance. So then you have to take this into perspective. You have to look at the MICs. You have to look at whether you are using phosphomycin as monotherapy or as a part of combination regimen. You have to look at the different sites of infection. If I apply the same principle to, let's say, a tigecycline in a biliary infection, the things are going to be totally different, because you will have such intense concentrations there that all these charts will be off. So that's why you have to take into account the site of infection. You have to take into account the MIC, whether you are using phosphomycin as monotherapy or as combination therapy. What is the room that you have for toxicity? If this is a patient in whom already you are struggling with dyselectrolytemias, then things might be difficult. So these are rough charts and these can guide you, but of course at the bedside, you have to take the entire picture into account while dosing these kind of patients. So what was done, he was started on phosphomycin 18 grams daily in 3 divided doses plus polymyxin B, and poly level was 2.9, and he clinically improved. Phosphomycin, the advantage is that sites of infection are not a major constraint as far as phosphomycin is concerned. So a lot of body sites where we have clinically significant infections, you will see good penetration of phosphomycin. What about minocycline? So minocycline is a highly or a fairly protein bound drug. Again, AUC MIC is the best predictor of clinical success. And like I said, for both minocycline as well as tigecycline, the site of infection is extremely important. So where is the infection, that is extremely important when it comes to drugs like minocycline and tigecycline. There are different numbers when it comes to the tissue to serum concentration ratio. Usually you would want an AUC, free drug AUC to MIC of at least 20 to 25. Now, if you look at the extremes, which means that you have an augmented GFR and you are giving, let's say, a standard 200 loading and 100 BD of minocycline, and if you take the other end of the spectrum, which means that you have compromised kidneys and you are giving 200 milligram BD of minocycline. So if you take these two extreme situations, usually studies will show that the AUCs will vary between about 5 to 10 to about 60 to 80. That is what studies have shown. So that means that you can use your MIC at the bedside and sort of gauge that where will my patient fit in this spectrum of, let's say, 5 to 10 to 80. And then roughly, these are rough calculations. Again, a lot of times in pharmacodynamics, especially in our settings, we have to go by rough calculations and estimate the kind of AUC MICs you would be generating for something like minocycline. Why this whole fuss about minocycline? Because as you will see later on when we talk about Acinetobacter, it's an important drug in our settings. So again, it comes to the MICs. So look at this. When you have a patient whose MICs start going above 2, again, it becomes difficult to optimize the pharmacodynamics of minocycline. And that's why definitely when your MIC starts going above 2, even when you're using minocycline as a part of a combination regimen, higher doses have to be given. If you have a low MIC, then you can look at, where your patient is on the GFR spectrum. If you look at the IDSA guidance, then they are, looking into very high doses, something like even 350 milligrams BD of minocycline. Now that's easier said than done, but at least we should be looking at the MICs, we should be looking at the GFRs, looking at where my patient will be on this AUC spectrum, what MIC am I dealing with, and then deciding the minocycline dosing at the bedside. Like minocycline, tigecycline also has high protein binding, and interestingly, it has atypical non-linear protein binding. So what does that mean? That the higher the dose that you give, actually the protein binding percentage can also increase. So it has atypical non-linear protein binding. So the percentage may not remain the same. The percentage might actually shoot up as you pump in more tigecycline. This is what I was saying, that tigecycline, the single most important factor is the site of infection. So if you have, let's say, a biliary infection, then even if your MICs are slightly high, you are in a decent situation to optimize the pharmacodynamics, because so much of the drug is going in there. So you may not go strictly by the breakpoints in the blood that have been given in the microbiological report. And last but not the least, I think this is the last one, last but not the least, you have sulbactam. So sulbactam is a drug that, we are increasingly using as a part of combination regimens for Acinetobacter. Again, we'll talk about it when we talk about Acinetobacter. So sulbactam MICs are difficult to get in clinical practice, because you can only get some vague idea with some surrogate MICs. So let's say using an ampicillin sulbactam, or let's say using a cephalosporin sulbactam and looking at the zone diameters, but these are not tests which are standardized to give you sulbactam MICs. So we really are not doing the manual broth microdilutions for sulbactam MICs. But if you look at studies for carbapenem resistant Acinetobacter, then a lot of times your median MICs for these type of isolates are high. They are about 8, 16, 32, and so on. So there is some data from East Asia about this. So let's look at, what happens when your MICs are low versus when your MICs are high. When your MICs are low, then look at the kind of doses and look at the kind of chances that you have as far as the probability of target attainment is concerned. Whereas look at an MIC of something like 16. Only when you give 3 grams every 8 hours or 9 grams per day as continuous infusions, you have green boxes there. So which means that if you have high MICs, which we often do without us knowing that, even worse situation, that we don't even know what MICs we are dealing with, we are just adding sulbactam as a part of combination regimen. We have to assume that for these type of carbapenem resistant Acinetobacter infections, we are having high MICs. So at least 8, 16, if not higher than that. If it is very high, something like 32, 64 or 256, one might even want to question the value of sulbactam in that type of a combination regimen. But anyways, let's not be cynical about it. So if you really have these type of carbapenem resistant Acinetobacter infections, that's where the total of 9 to 12 grams per day of sulbactam comes from. And this is the renal adjustment. So this has been, we've used a few resources to sort of formulate this chart. But this is the renal adjustment for crab. So remember, that's not the same as your ampicillin sulbactam renal adjustment. So because here you have the luxury of giving your patient plain sulbactam, unlike in the Western world. So these are the kind of doses that you would use for renal adjustment when you're treating a carbapenem resistant Acinetobacter. So I'll summarize by saying that, PK/PD aspects are important to optimize therapy. We have to think of what is my PD target for that drug, for that bug at that site. All these three parameters are very important, which is the organism, what is the MIC, what is the site of infection, and what is the antibiotic that I am giving. Is it something which is used as monotherapy or as a part of combination regimen? How much of it gets to that site? And then what are my targets? So based on that, you will have to think of dosing strategies. For drugs, for commonly used gram-positive drugs like vancomycin, daptomycin, teicoplanin, linezolid, we use AUC MICs, which means that you look at trough levels, in some situations peak levels, if possible get access to AUCs, then look at the MICs. If not, at least look at the MICs and look at the kind of dosing strategies that you will have to use. Like we said, high doses for teicoplanin, high doses for daptomycin, and so on. Polymyxins also, AUC MICs are used, but access to TDM is a little bit of a challenge. If you do have it, then it helps to a certain extent with polymyxin B, because there at least you have some margin. With colistin, it is very, very difficult, because one thing is that you have very little margin there. Sorry? Yeah. So because you have very little margin there, and also the fact that, the toxicity thresholds are low. So there are several different constraints, and PD targets are also very, very difficult with polymyxins, both polymyxin B and E. Tetracyclines, as we saw, again, AUC MIC is important, but looking at the site of infection is critically important. For beta-lactam drugs, it is time above the MIC. For beta-lactamase inhibitors, it's the concentration threshold. So like we said, there is a difference between the CT target for avibactam with ceftazidime versus the CT target for avibactam when it is used with Astonam, and that is what gives Astonam avibactam a slight pharmacodynamic edge. Data for TDM of antibacterials is emerging. Access to TDM and cost constraints remain important challenges in our settings. For vancomycin, we looked into this. For teicoplanin, TDM may help in improving efficacy more than safety, because you have quite generous targets when it comes to the toxicities. For linezolid, at this point of time, most of the literature supports TDM mainly for reducing toxicity. Daptomycin TDM is still not standard of care. Polymyxins TDM, like we said, may have a role, but access is challenging. And again, aminoglycosides TDM is important, especially when you're trying to minimize the toxicity. I think I'll stop here. Thank you once again for inviting me.
Just a comment. The science behind all this is very, very robust. Unfortunately, the evidence is very difficult to generate, and many trials have been done and have not really lived up to our expectations. And one of the important things is obviously the ICU mortality is driven by many other things which are downstream of the PK/PD considerations, and therefore it is still difficult to demonstrate a very, very good impact overall. And compared to that, you need a dedicated line, you need more resources, nursing time, and so many other things which can also negatively impact. And therefore, we are still struggling to show evidence.
Right.
That is a big issue. I was under the impression that the target for fosfomycin is actually time above resistance inducing concentrations.
That's
rather
also one of the
than
targets
AUC
used.
over
Yes, that's also one of the targets used, but the dosing charts have used mainly.
AUC
Right.
over. So that will be another important challenge is, do you look at colistin sulfate measurement or colistin ethate measurement?
Right, absolutely. That has
So
been the
that is
challenge.
also a big challenge.
Absolutely.
So
And also free and
what-
unbound drug also.
Yeah.
Sir.
So what do you do it?
We are mainly doing polymyxin B levels.
Colistin
Colistin is
becomes one
difficult.
more
Yes.
challenge.
Colistin is very
what
difficult.
are you actually measuring?
Right.
And the fully methane sulfonated, 5 methane sulfonated molecules, or any of the intermediate ones, or the last colistin.
Absolutely.
Sulfate itself.
Yes.
So lots of challenges.
Challenge. I agree.
Excellent talk.
Thank you.
Any comment, questions, please?
So the monobacterium requires more protection.
Right.
Why is that?
So for example, if you have, so it really depends on the IC50s of enzymes. So if you have other enzymes in there which are really voracious hydrolyzers, then you really want to have higher levels of the BLI to give Astronom that sort of a protection.
And also whether they are suicide inhibitors
Right.
or
Right. Reversible suicide, all these things. Absolutely.
Sir, hello. Sir, the role of beta-lactam monitoring in augmented renal clearance, would it actually help? Would it improve the mortality?
So, as sir said, showing that it improves the mortality is very, very difficult. What we can study is, whether we are really reaching the pharma or meeting the pharmacodynamic target. In that sense, yes, there is a role. Like I said, the trials really haven't shown robust benefit of TDMs in terms of outcomes of patients. But, as Suman sir said, when you measure outcomes or keep outcomes as the endpoints in these type of patients, it's very, very difficult because so many things influence that. But purely from an optimizing the pharmacodynamic target point of view, it is used.
This whole science helps you for drug development.
Right.
And even setting breakpoints.
Absolutely.
So, the science is extremely robust.
Right. Absolutely. So, for example, take something like Burkholderia, for which now the breakpoints have been abolished. We don't have anything to go by. If the lab tells me that the meropenem MIC is 4, what do I say? Whether it is sensitive, whether it is wild type. So you can't just go by these things. What is important is that will I be able to meet my pharmacodynamic target with that sort of an MIC? That's the only information we are left with as a clinician, to deal or to interpret that MIC.
Otherwise, you do follow up blood test. One more indication.
Any other questions? So then just a query in my mind. So if the PKPD was extremely important, and we still recommend a prolonged infusion of the beta-lactam, but the Blink3 showed a negative aspect. So how do you say that a negative trial is still driving the concept of a prolonged infusion for beta-lactam?
That trial was just one part of the evidence. If you look at the overall evidence, there is still plenty of support for prolonged infusion. So that was just one study, and there were several factors in that study. But again, while this concept of prolonged infusions is important, whether it is going to affect our outcomes is very, very difficult. So how I look at it is, in patients in whom you have pharmacokinetic constraints. So let's say, I have a patient who has augmented renal clearance, source control has been difficult, is in shock. So in these kind of patients, it is extremely important to optimize that. For all, so the classic case is, the combination of ceftazidime avibactam plus Astronom versus Astronom avibactam. That 10%, 15% difference in the pharmacodynamics that you are getting. So your chances of, the PTA are, let's say, 85% here versus 95% there. That 10% difference may not be applicable to all your patients. Let's say you have a Klebsiella whose MIC is 0.25, the patient is otherwise doing well, that may not matter. But now I have, let's say, a Pseudomonas, wherein the synergy has been sensitive, but the MIC is, let's say, 4, or Klebsiella, wherein the MIC is 2, he has cholangitic abscesses in the post-liver transplant setting, septic shock, source control difficult. These are definitely the kind of patients in whom I would like to optimize my pharmacodynamic targets. That is how I look at beta-lactam optimization.
And see, the largest trial to my knowledge to date is one from North America, which has been a retrospective trial published in JAMA, and the first author is Karaba, and also Pranita Tamma, and all those, they are all there. So, yeah, Jason Roberts. So in that, actually, the adjusted odds ratio, I don't understand too much about what adjustment they make, but it was 0.71. So there was a clear benefit in terms of mortality in that trial. So that is, to my mind, the strongest clinical evidence of benefit of using extended infusion beta-lactams. But short of that, but even that can be argued, because in that they showed that there were excess problems related to adverse effects and the thrombophlebitis and all these things were worse. A few more caveats in my mind. I don't have the right answer. Maybe all of y'all can tell me about it. This should be most applicable for bacteremia. Because see, if you are an extravascular site, then it is not just because see, then you cannot say what is the time above MIC in the CSF. How the hell are you going to know that? But you must have at least enough drug penetration into the CSF for it to then talk about time above free time above that and so on. So for bacteremia, it may be important. For urinary tract, I would say for a beta-lactam, it might be the other way around. Because the more the time the drug spends in the circulation, the less time it is spending in the urine. Don't you think so? So, the issue is not as simple as that. Aruna, look, that's something.
Wonderful job of describing all the PKPD's issues. I was just thinking that suppose when you don't have the TDM, a patient of a sepsis, can we do with the biomarker understanding this aspect? Like suppose procal, you are going to assess the procal continuously and overcome this scenario. Because I am just always think that we teach them well, but suppose they don't have the service or facility available. So in a resource limiting situation, can we do this part?
So, sir, I would say that in a resource limited setting, rather than biomarkers, what you would really look at is the MICs and trying to optimize the doses and looking at pharmacokinetic constraints, because biomarkers, the kinetics are also very variable. So, sort of tying the biomarker response and using it as a surrogate for pharmacodynamics, in my mind, wouldn't be the way to go about it. It would be more of looking at your pharmacokinetics in detail, looking at the protein binding of the drug, what is the albumin of that patient, and then trying to come up with dosing strategies. That's the best that you can do in this type of situation.
I always like to take some issue with him. So the biomarker itself is such a costly affair. PCT, first of all, currently PCT, I mean, we have a lot of ICU audience here. PCT almost should not be done on, except for neonates. It's almost come to that. And we are merely asking for PCTs on a daily basis. See, if trying to say that PCT has not improved, that's why now I have to make some changes in my dosaging and as well as administration pattern. I think is we have missed the bus then. These things will have to be done very soon, if at all. So right in the beginning, when is the time that you want a maximum effect? Not after the chap has failed, not in the realm of salvage. It is in the realm of initial management. So your initial management, you will have to really think and have high doses, loading doses, optimize all PKPD considerations. All that is to be done in the first day or two.
That's also one of the issues with TDM also, because you are going to know that after 3 or 4 days of teicoplanin that what your levels are. So the best thing is actually to have something like MIPD, which is model informed precision dosing, which gives you the doses when you're starting out therapy, not after 2 or 3 days that you have looked at. And again, some of these targets are, the target, but you don't know how to get there. Our program director used to say that many times.
I find teicoplanin being used, just thrown in as a something that I have covered gram positive. Beyond that, it has no meaning. So nobody is really bothered for as a directed treatment. How often are you using really teicoplanin, except for osteoarticular or some infections where probably it doesn't matter so much in terms of life and death. It is a matter of lack of response.
Also, one may argue that for a serious ICU infection for directed therapy, teicoplanin may not be a good choice at all. So. And again, so many issues with volume distribution, protein binding. So the patients in whom teicoplanin does well are the patients who don't need teicoplanin to be.
So again, a personal question to Dr. Rajesh sir. So regarding ceftazidime, ivermectin, and aztreonam, I think you changed your practice from co-loading to starting with one infusion and then adding aztreonam after half an hour to 1 hour. Did you change your practice or was that just a paper? And now that you have the aztreonam ivermectin in the market, would you prefer ceftazidime, ivermectin, aztreonam as a triple combination or aztreonam ivermectin straight away?
Yeah, but I couldn't. In the face of so much of international work, so much of thousands of patients estimated with Monte Carlo and all that, I am sort of keeping it back. I just had a poster where I found in 5 patients where TDM was done, I had excellent results. And there it was yeah. So, my idea was to begin the ceftazidime avibactam half an hour before the aztreonam. Why? Because aztreonam I don't want to get killed I want some avibactam there. Then I give a half an hour infusion of aztreonam. Again, the idea is that aztreonam will penetrate into the sites of infection which I want. And aztreonam has a natural long-acting, is naturally long-acting. So at the end of 5 hours, I was able to show that I had minimum aztreonam level of 16, and 16 happens to be 4 times more than the putative breakpoint. And I had more than 2.5 of avibactam all the time, even at the end of 5 hours. So I was meeting these targets with this particular method, but I have only data of 5 patients, and it was only a PK data. So beyond that, I can't say anything more. Now, once that this method has come, one should probably adopt this. Encourage, interestingly, both the drugs are available from separate generic manufacturers. So, this problem to some extent can be solved. Otherwise, one of the things which we discussed that day is maybe you, without any interval, you begin the next infusion. 1/3 of the amount in the next 1 hour. So it looks as if you have given that 667 as a loading dose. It's not exactly how you would want it, but more or less it will probably be better than discarding 2/3 of the vial or doing something like that. Expensive also. About the next question, which is very difficult to answer, is does ceftazidime work in any way as an additional thing, or is it just avibactam aztreonam? So ceftazidime would also saturate 1 and PBP 1 and 3, which will be somewhat better if one goes by the complementary saturation of BBPs as the hypothesis for working when one of them, when you don't have other things, so you don't have a NDM active drug and so on. So maybe there is some benefit in that, but we don't know really whether that is just for that you should be using another drug or not. It's very difficult.
Thank you, sir. Any other questions? Please.
Hello, sir. Very good presentation, sir. Just one small doubt, sir. In a patient who has a sepsis-induced AKI, do we need to dose adjust there also, or should we give a full dose and then later modify?
The short answer to that is, full doses, at least initially, because again, sepsis-induced AKI, what you see in terms of the creatinine is actually not reflecting a lot of the pharmacokinetic changes that are going on. So the short answer to that is, at least for the first, what I do is for the first 24 hours, not modify the dosing.
There's an excellent editorial on that about jumping the gun. I'm sure you have read that. So this AKI also resolves very fast in 48 hours with effective treatment. So instead of even 24 hours, it might be for 48-hour time point, after which you may want to reduce the dose. So I think we have to be very, very careful. Maybe actually have a measured 6-hour creatinine clearance. Maybe we can do that also in the ICU. It's not a bad thing to do, to actually measure it. I mean, so many things are being measured, so you already have a catheter there, so not a big difficulty. So if you actually measure clearance, you can find out when somebody is having a clearance of more than 120 or 130, and when is it dropping down, and so on. So that is something which we can very easily do. It's not going to be costly at all. It's just a matter of calculation. Yes. Right. Also, yeah. Measurement is the only thing which you can do. Short of doing TDM, you can just look at the clearance, whatever is happening, whether that can help. It was something new to me, Pariksha, in your lecture, that minocycline we know has a good amount among the tetracyclines. It has a good renal clearance, but they actually looked at renal clearance with this thing. That's something very interesting. Yeah, because as you said, minocycline we do have to use when our back is against the wall for Acinetobacter, but it's important.
Emergency. So I think beta-lactams, you don't have to really worry about toxicity upfront. You can give full doses.
So like I told you, the neurotoxicity is way above, even 10 to 15 times the MIC. Usually it is in the triple digits.
But in actual practice, we are always facing counter arguments from neurologists. More than neurologists, they will blame all seizures activity on your beta-lactam.
So if you look at data, except cefepime, most of the other drugs do have quite high level.
I think we are running out of time. We'll take care of this later.
No. We sincerely thank you, sir, for enriching section. Let's begin with the next session on modern microbiological diagnostic in ICU from conventional culture to next generation sequence by Dr. Geetu Joy. She is accomplished infectious disease microbiologist with clinical and academic expertise in diagnostic microbiology and hospital-acquired infections. Dr. Geetu has contributed to several research publications in field of infectious disease and is actively involved in critical microbiology practice, research, and academic training. We look forward to her valuable insights at this conference. Ma'am, please.
So, good afternoon, everybody. I will be speaking on microbiological diagnostics in the ICU. I'll start by introducing these two important figures to you all. Fanny Hess, she is the woman who was responsible for introducing agar into culture media. She actually invented the idea of adding agarose into the culture media so that you could solidify it and then you could make a solid media by which you could grow your microorganisms over that. And he's Frederick Sanger, who's responsible for Sanger sequencing. So I have divided my talk into what is promised by the diagnostics. I'll start with that. This is my first subsection. What is promised by all the microbiological diagnostics? And whether they have fulfilled the promise, we'll come to that. So this is a 55-year-old male patient, a live donor liver transplant for chronic liver disease. He had received many courses of various antibiotics earlier. He developed a stricture, cholangitis, and bacteremia. So in such a scenario, when this patient has a bacteremia, what are the organisms that we are suspecting, expecting, and what would be the empiric treatment of choice? So because he has been on multiple antibiotics, we are expecting carbapenemase resistant enterobacterials, for which the treatment of choice will be casavi-aztreonam. We are expecting anaerobes, for which we would like to give metronidazole. For enterococcus, we would want to start teicoplanin. All the above could be covered by tigecycline to an extent. Even candida, for which we would want to give micafungin. So in this patient, on the flag positive blood culture bottle, a BCID biofire, which is available in-house in our setup, was done. And what were the results of the BCID? Enterococcus faecalis faecium, which we were actually suspecting, was absent. Bacteroides fragilis was absent. Among the enteric bacteria, we found Klebsiella pneumoniae. No other enteric bacteria were found. And what about the candida? No candida seen. And in the resistance markers, we got only CTXM, which is an ESBL marker, and OXA48. We didn't find any NDM. Upon which we could give a directed therapy. We could convert our empiric therapy into directed therapy. Casavi-aztreonam could be converted into only casavi. We could minus out the metronidazole, teicoplanin, micafungin. So basically, by doing this particular test, inappropriate, broad or inadequate or toxic empiric treatment could be avoided. Casavi alone rather than the others could be given. Combination with aztreonam, we all know, is potentially hepatotoxic, so this could be avoided in this patient. So the BCID has fulfilled this promise, we can say. Now moving on to another gram-positive case, where let us see if the promise was fulfilled. This was a 61-year-old male patient. He was a diabetic alcoholic. He had an acute onset of severe neck pain and fever, had leukocytosis. The blood cultures were reported as MRSA. This was an outside culture report before the patient came along with the blood culture report. Upon identifying it as MRSA, he was treated with vancomycin for 10 days and he had persistent fever, developed a left upper limb weakness, and then was referred to our hospital for further management. So he had a prevertebral abscess. The culture report seemed dicey to us because there was no mention of the markers of MRSA. How have they called it MRSA? There was no cefoxitin screen, no oxacillin mentioned. The previous hospital or the lab were kind enough and they kind of shared the results. I won't go into much details. What I only want to mention to you is that the machine had made its interpretation. Probably there was some broth contamination. Oxacillin MIC was actually susceptible. Cefoxitin screen was converted. So we had a doubt that this was MSSA. But the patient had already received antibiotics, vancomycin for 10 days. His blood cultures were sterile now. So it was decided that whatever prevertebral abscess, we wanted to do a prompt source control and give a targeted antibiotic therapy. So whatever prevertebral abscess was drained, it was subjected to a joint infection biofire, by which we got this result. It was a Staph aureus which was actually methicillin sensitive. There was no MECA MREJ found. So again, in this case, this particular multiplex PCR fulfilled its promise. It gave us the right bug. It gave us the information of the antimicrobial resistance gene, whether present or absent. Another quick case of a 34-year-old female. She was a known case of carcinoma ovary. She underwent a total abdominal hysterectomy, pelvic node dissection. She had high-grade fever and abdominal pain in her left iliac fossa. She had received again lots of antibiotics, third generation cephalosporins, azithromycin, ofloxacin in the 10 to 12 days following the fever. Her PET scan showed a iliac collection. It was aspirated and the gram stain shows slender, long gram-negative bacilli, if you can see. All these are the gram-negative bacilli. Many of them were seen, but nothing grew in the cultures. So why was there no growth on the bacterial culture? The patient we know had received multiple antibiotics before the aspiration. Antibiotics were not withheld when she was being aspirated. And could it be any anaerobes that we were dealing with? That is why we couldn't grow them on the aerobic cultures. Anaerobic cultures were not sent. Again, this highlights the importance of suspecting anaerobic infections in the right clinical setting and sending the required material for the same. So we send this for sequencing to another center. We do not have sequencing at our place, and it was identified as bacteroids. Another case where the promise was kept. So this was another diagnostic. I'll come to that. A lung biopsy granuloma. AFBs were seen, acid-fast bacilli. It was expert negative, raising a suspicion of atypical or non-tuberculous mycobacteria. There was a coding seen which indicates virulence of NTM, and we wanted to know the ID, as treatment is much more difficult for Mycobacterium abscesses in comparison to Shilloni and Fortutum. And the MALDI helped us in this case. It was Mycobacterium abscesses. Now it is known as Mycobacterioids abscesses. Another case where MALDI came to rescue, an elderly patient with infective endocarditis. Vitek was giving a slash line, Granulicatella and E. fecalis. On being separately selected, they were giving lower confidence rates. But does it matter whether it is a Granulicatella or an Enterococcus? Yes, because the treatment has to be decided accordingly. E. fecalis, if not penicillin resistant, can be treated with a double beta-lactam and aminoglycoside can be avoided. Whereas Granulicatella should be treated with a penicillin and an aminoglycoside. So whatever was promised by the above tests, a few biofires, MALDI, sequencing, all that has been fulfilled. So what is not promised by certain diagnostics? This is a 36-year-old male. He presented to our hospital with one episode of GTCS. They had mentioned as a head injury which occurred a few days ago, 5 or 6 days. The history was reviewed where it was just a trivial injury. It was just a seat belt injury, not a head injury per se. The patient had presented with headache and GTCS. HRCT showed some nodules. MRI brain showed a subdural empyema. The fever was way before that seat belt injury or trivial injury. It was for last 15 to 20 days. Blood cultures were sent from the ICU. Flag positive for gram-negative bacilli. Now this patient is coming from the community, not exposed to any antibiotics. So the first suspicion was salmonella. To hasten the process of identification, a BCID panel was ordered. So BCID was negative. Salmonella is included in the panel. but it wasn't detected. So could it be an off-panel organism? So the promise actually has not been made by the BCID for the other organisms which are not included in the panel, like Aeromonas, Pasturella, Burkholderia pseudomallei, Ralstonia, Chrysobacterium, Elizabeth kingia, but again they are nosocomial organisms. So the blood cultures were plated. The next day we saw these classical carom coin colonies, and the colony smear showed a safety pin appearance, which were very well characteristic of Burkholderia pseudomallei. So with history as well as the colony appearance, the cultures, we got a suspicion that this could be Burkholderia pseudomallei, and in fact it was that. Amoxiclav disc susceptibility is also a very important test which is done in the lab. And upon reviewing the history, we got to know he was actually a diabetic, chronic alcoholic. He hailed from Konkan region, had visited his native a month ago in the heavy rains, did some agricultural activity. He had not been hospitalized. The fever was for 15 to 20 days. So the trivial injury was actually not the cause of whatever GTCS and neurological abnormalities it has. It was actually a pulmonary and a neuromyelioid. So melioidosis, the challenges we all know, these are the comorbidities, climatic conditions, the areas in particular, and delay and missing the diagnosis. Even on Vitek, it can get misidentified, and even the clinical presentation, it's a clinical mimica. So this was a similar paper that was published, that neurological melioidosis presented as a subdural collection in some laborer population in India. So now quickly moving on to another promise that was not made in the first place. A 53-year-old female, she was a diabetic, hypertensive, had complaints of cough, loss of appetite. She was a known CKD who was on maintenance hemodialysis twice weekly. Blood cultures were sent and were awaited. She had leukocytosis, neutrophilic leukocytosis, and lung imaging showed certain ground glass densities, and they were likely to be septic emboli. At least this was what the ID team thought, more than the infective etiology. The reason being that her blood cultures flagged positive by then, and bacteremia secondary to pneumonia, is the incidence is very less, only 10 to 12%. And she was more likely prone to a CRBSI. She was undergoing dialysis and lung cavities because of that. So possibly it was a hematogenous lung abscess is what we thought. So the organisms causing these lung abscesses could be Pseudomonas, Burkholderia cepacia, Staph aureus. By then the blood flagged positive, and it was gram-positive cocci in pairs. A BCID wasn't done. A bronchoscopy was subjected to an LRTI biofire, but we couldn't see any Staph aureus detected over there. It was only Haemophilus influenzae, 10⁵ bin copies. And other tests, galactominin, gene expert, all were negative, and cultures were awaited. The blood culture came out by then. It was actually Staphylococcus lugdunensis, which is not there in any panel. And it was a methicillin susceptible Staphylococcus other than Staph aureus. Now cons is known as SOSA. The same thing got isolated in the bile culture. So the theory that we actually thought was true. So it was a hematogenous seeding of the lung. Staph lugdunensis got isolated from the bile cultures as well. So this particular species of cons or SOSA is more virulent because of the different virulence factors that it produces: edesins, enzymes, biofilm production, delta toxins, etc. So now that wasn't promised, the previous two cases. What about the promise broken? An example for that, this was a 38-year-old male patient, had multiple prior hospitalizations elsewhere, was admitted with high fever and sepsis. He had a high-grade bacteremia due to severe liver dysfunction and extensive porta-systemic shunting. The blood cultures flagged positive and it grew GNB. Next day, when the growth came, it was inquired whether it was a lactose fermenter or not. So it looked like E. coli, and then they wanted to know the resistance marker so that they could optimize therapy accordingly. And they asked for a rapid carba on the lactose fermenting isolate, which looked like E. coli. So a carba rapid test was used. There was no CR enzyme detected, and it was reported as negative. But this was very surprising. A reference was given to to the ID team later on, because he had received extensive carbapinums. And is there a possibility that NDM could be missed if there is a lower enzyme expression? An expert carba was asked for and NDM was detected in fact. So what are the possible reasons? Expert carba is a superior method. You're detecting the genes directly and it is more reliable. Sensitivity is more, it's up to 90%, particularly in high risk setting as this patient. Rapid carba, they are useful low cost tool, but sensitivity again is compromised. It's only up to 70%. It depends on the extent of enzyme expression, which again depend on several factors like the inoculum, the temperature, time of incubation, where have you obtained the colonies from, have you used a zinc supplemented Muller-Hinton broth, etc. for detecting. So high clinical suspicion of, in this case, prompted disbelief in one of the particular diagnostic tests and further testing was done which led to the appropriate treatment. The same is shown by Balaji sir in his work where he had tested more than 100 isolates. He compared PCR with the lateral flow where you can see there was a good concordance but one isolate NDM was missed. Then moving on to what further diagnostics will you do? Now you have detected a carbapinamase marker. A synergy was asked for. The reasons were very well explained earlier. And even in the AST, ertapenem, imipenem, meropenem were resistant. So this is the broad disc elution method which was shown to you earlier. You can see it was susceptible to the combination. The broth is clear over here. And this method is recommended by CLSI. So why do we do the synergy test? As explained earlier, once again by studies done by CMC, Astronam ebibactam is susceptible in E. coli isolates only to an extent of 72%. So, but broad disc elution, you will not get to know the MICs. It will only be reported as whether it is susceptible or not susceptible based on the clearance of the broth or how turbid. If the broth is even a little turbid, then it is reported as not susceptible. But whereas there is another method where you can incorporate an E strip, Astronam ebibactam E strip, where which has a good essential and a categorical agreement to the BMD, which will give you the benefit of getting an MIC. So here you can see the Astronam ebibactam E strip, the MIC reported was 0.38 in a CR Klebsiella. Now moving on to another promise broken, more than a promise broken, I would say I put up this case to show you the diagnostic challenges that we faced then. So he was a 44-year-old male patient. He had a periesophageal and a perigastric inflammatory lesion. That time also in an outside hospital, sparsely septate hyphae were reported. He partially responded to voriconazole. After 1.5 years, he came to our setup. He had a massive liver lesion. He had hepatic venous thrombosis. It was refractory despite restarting posaconazole. A surgical excision of that large liver lesion was done. And there was an uptake in the PET scan, the histopath, the KOH, the GMS done, the calcofluor. All of them were slender in comparison to mucor. The uptake wasn't that much. If you can see the calcofluor, they usually in mucor you get beautiful uptake. The septa were sparse. Even in GMS, the the silver stain that is there, the uptake wasn't that much in the filaments. We obtained a waxy growth, which was beyond our scope to identify. So we sent it to PGI for sequencing. We also sent the sample along with the isolate, which got identified as Pythium insidiosum. So this was actually the first human case of systemic disease due to Pythium insidiosum reported from India, for which we published a poster in the ESHA. Now, how to use the promise slyly? This was a 40-year-old male patient, decompensated acute liver disease. He had coagulopathy, headache, seizures. You can see he had cerebral abscesses and he had lung nodules with halos. This was from his pleural fluid, narrow, septate, acute angle branching filaments. So there was a suspicion of invasive pulmonary aspergillosis. Did he have a CNS aspergillosis along with that? For which we did a serum galactomannan. It was very highly positive, 6.5. CSF was also subjected to a galactomannan ELISA and the OD value was 1.5, which we have reported as positive. How? Based on this literature, where the diagnostic performance of galactomannan antigen testing in CSF was studied, where ODI cutoff of 0.5 to 2 was used, where you can diagnose cerebral aspergillosis by virtually ruling out, you can virtually rule it out without the need of a cerebral biopsy. And it also produces BDG. So even BDG was performed on the serum as well as the CSF samples. 1.66 was reported as positive. The cutoff reported in the literature was 110 picogram per ml. So this also can be used for diagnosing or excluding fungal CNS infections. Another quick case, this was a 62-year-old male patient. He had a bilateral EVD insertion which was done outside for a intraparenchymal bleed. And then he came to our setup, he was febrile. So whether it was a central fever or whether it was infective. CSF lactate was positive, but this can also happen because of the red blood cells. The organism suspected based on the epidemiology of the previous hospital were Staph aureus, Pseudomonas, Klebsiella, Candida, Burkholderia, Acinetobacter. So how will you rule out all of these? He had already received antibiotics. Culture negative could not be sure. So we tried to use whatever was available at our setup as a rapid test. So we subjected that CSF to a LRTI biofire which included an Acinetobacter because we really wanted to rule that out, and also to a JI panel. It did not have Acinetobacter, but it had Candida, Pseudomonas, Klebsiella was covered by both. So this is already in the published literature, use of joint infection biofire for accurate and rapid pathogen detection across a variety of clinical samples, enabling timely and targeted therapies. Another quick case, a 3-month-old child, he had complaints of fever, cough, cold for 10 days, admitted in an outside hospital, received lots of antibiotics. He had a left-sided effusion with empyema. This child was admitted to PICU, was receiving oxygen by nasal prongs in view of tachypnea. Empyema was subjected, he underwent a VATS surgery, and whatever intraoperative pus aspirate was collected. Now we really wanted to know, he was on antibiotics, cultures, blood cultures were anyways negative. We were not sure that the intraoperative samples would also grow. So we subjected it to a Binax test. This is actually known as a urinary antigen test for detecting pneumococcus. But there has been published literature where we can use it both on pleural fluid as well as CSF samples. So we did the same and we got to know that it was actually invasive pneumococcal disease. This is my last case. A 68-year-old male patient, fever, body ache, joint pains. We do an acute fever panel on TrueNat in our hospital. So on the TrueNat machine, we have individual cartridges for dengue, chikungunya, leptospira, malaria, and all of them we have combined into an acute fever panel, out of which chikungunya was positive. This patient was hospitalized, received symptomatic treatment and got discharged. But in 2 days, he came back, he was drowsy, he had absent power in the lower limbs. A CSF was done, lumbar puncture, which showed 90% lymphocytes. He had neuropathy, and chikungunya PCR was done on CSF, which was again detected, confirming this was chikungunya encephalitis. Again, a TrueNat cartridge for chikungunya was used. So, I would like to conclude by saying that the emergence of multi-drug resistant organisms has led to use of broad spectrum empiric therapy as a standard care of approach. If we resort to only conventional cultures, then it will take quite some time, at least a minimal of 72 hours. Decreasing the time the patients are on broad spectrum therapy through rapid diagnostics not only ensures appropriate treatment but also reduces the AMR. So genotypic tests, again, they have a complication of higher cost. So they can be used in a complementary fashion to the traditional phenotypic methods. To become accessible as a POCT, they have to forego expensive devices, laborious sample preparation, and high-tech laboratory facilities. I would say BioFire and TrueNat leave about the expense, at least when it comes to the laborious sample preparation. Both of them are closed PCRs. They do not require higher technical skill. Everything is happening within the machine, and you actually do not need a PCR based setup in your lab. You just have to install the machine and everything is happening within the cartridge. So these rapid methods collectively provide rapid typing of ID, AMR genes. They give you more confidence in your treatment selection, leading to improved outcomes. So the modern diagnostics, but they are not competitive. They will always be complementary, not intended to replace the routine. They need good clinical correlation, knowledge of epidemiology and resistance mechanisms. Clinicians always want better, faster diagnostic tools. The primary challenge is encouraging the clinicians to also act on the results provided by these tools. Thank you. Any queries? Any comments?
So how much confidence you have got using the respiratory panel?
Sir, the URTI in fact has given us a lot of confidence to rule out viruses. The LRTI, if the sample quality is appropriate, then I think it is a good test. Again, we measure the bin copies, and then in that also the viruses are covered. Soman sir, I'm sure he'll have further comments.
I think that test has to be contextualized very, very well. It is one of the most difficult tests to interpret. In fact, unless the clinical correlation is there, you have to know what you must have a differential diagnosis even before you do the test. And then you decide out of that what to use, what to discard, what can be discarded. And not only that, after that, you must have a very good working relationship with the pulmonologist or the critical care physician or any other physician under whom the patient is admitted. Because let me tell you, my major work as a ID physician is to stop, de-escalate, terminate therapy rather than adding anything. Adding is a simple matter today. I think everyone is on meropenem, teicoplanin, and maybe one of the antifungal agents and so on. So my main work is to de-escalate. कि बस करो अभी ये इसका ये तो नहीं है. So to say that, I need to convince the person even when some genetic nucleic acid material has been found. So look at the clinical syndrome, whether that makes any sense. Look at the bin value. Look at what other things are there. If you have a pneumonia and you have 5-6 different organisms, all of the same bin values and all that, then it does not really make sense. So how much sense it makes, I think there is a lot of clinical judgment. We are learning. Basically, we cannot say that we know everything. So what comment Aruna Lok has said, and even Camila has not allowed LRTI biofire in Hinduja Hospital. That merely means something is there. I would not say don't allow, but a lot of interpretation is required. And we could go wrong anytime. I mean, I frankly admit that.
Yes, you can know about some of the viruses which is not being detected by any other process. But the thing is that no, these are the
And also we must know what is not there. For example, nocardia is not there, Burkholderia melioidosis is not there. So those things the clinician must also know what is there on the panel, what is not there on the panel. Is it high on my suspicious list? In which case appropriate further testing is required.
Thank
Any other questions?
Thank you, ma'am, for such a clear and impactful session. We now move on to the plenary lecture on Candida infections in the ICU, including fungal peritonitis. Ladies and gentlemen, it is a rare privilege to welcome a true titan of medical mycology to our CME today. We are honored to introduce Professor Dr. Aruna Loge Chakraborty, a luminary with over 41 years of experience in fungal diseases, who has authored 477 research papers along with other remarkable achievements. He is one among the most impactful medical researchers in the world. His laboratory holds the rare and extraordinary distinctions of being the only WHO collaborating center in the world for reference and research on fungi of medical importance, and is also recognized as the Center of Advanced Research in Medical Mycology in India. Sir has served as past president of International Society for Human and Animal Mycology, chairs the Asian Fungal Working Group, and serves as chairman of the Fungal Infection Study Forum. Crowning his career, he has recently awarded by the American Society for his exemplary leadership and extraordinary contribution to the science of microbiology. Please put your hands together and give the warmest welcome to the man who has redefined the frontier of medical mycology. Sir, please.
Okay, good afternoon to you all. Thank you for bringing me again here, and I would say that this is real interest in it. My topic here is the invasive candidiasis in ICU, including Candida peritonitis. You heard throughout the morning the bacteria. Now we have got the before lunch we have the chance of discussing fungus. I'm sure you are hungry, but I will try to finish it as quick as possible. But there are certain problem is there in case of this diagnosis and management of these factors. So I'll try to elaborate those are the problem areas in this aspect. First thing is that what is this invasive candidiasis in case of your ICU? There are two areas. Of course, we know Candida sepsis or candidemia, which is one of the major factor. And second issue is that which is not being given much importance. Now people are looking into it is the localized abscesses which we do see, and these localized abscesses seen in case of the intra-abdominal infection. You know, this is one of the area where people used to say, okay, we have hard spontaneous bacterial peritonitis. Is there any spontaneous fungal peritonitis? And it has been seen that though the numbers are not much, 3.5% which have been there, but it has shown that is worse prognosis which have been there, especially in the patient with severe sepsis, septic shock, and the overall mortality compared to the spontaneous bacterial peritonitis is much higher than this. Additional problem which we see is that in case of this abdominal candidiasis is the diagnosis issue. You know, Candida, when they come in contact with the peritoneal fluid, it has shown that it acquires some more virulence factor. And because of this, it is producing much more aggressive disease compared to the disease which is seen in other places. And here we need the surgical sample to diagnose it. And that is not possible. Only thing is that if you have done the surgery, that is the only way you can do it. Some people say, okay, why not the drain fluid can be cultured? Drain fluid, if it is within 24 hours, it is accepted, otherwise it is not. So what is happening that clinician, whenever they are suspecting something is there, they'll add some antifungal in it. But if you see that the mortality is not going down. Second important issue is that whenever we say of Candida, our mind always goes with echinocandid. But here what it has been seen in case of the peritoneal fluid, echinocandin penetration into that area is much less, really less than 1/3 it is going inside the peritoneal fluid. So I will come to it why the PKPD issue becomes a problem in this area. So with this bit background, what is this invasive candidiasis? Let's see what is the progress have been made over the last couple of years, I would say. First is that we have some rough estimation of the magnitude of the problem. Second thing is that understanding about intra-abdominal candidiasis has really improved. I will come to this. And there is a global guideline which have been published in case of the how to manage and diagnose in case of the invasive candidiasis. And there are new drugs which are coming up. Rezafungin. Rezafungin is the drug where it's an echinocandin, but it can be given once in a week. It's not daily you need to give it. So that is very important. Another drug which is becoming very important, especially in Candida auris. You know, Candida auris, which is found to be even resistant to echinocandin, where possibly ibexa would be important. But whenever we are progressing, we are facing also new challenges. One of the major issues is the Candida auris, which is now become pandemic across the whole world, and now it is seen in 80 countries in the world. And this particular bug is very difficult to manage, and it contaminates the environment very fast, especially in case of your ICUs. Validation of the fungal biomarker in ICU, still there are a lot of gaps. We do see certain amount of standardization in case of your galactomannan is there, but beta-glucan still there is challenge in case of this standardization. Despite overall improvement in ICU care, what we are seeing that the mortality in invasive fungal infection is not coming down. And we are seeing certain newer problems like so-called innocuous species like Candida tropicalis, Candida parapsilosis, where fluconazole resistance is coming up. And of course, we need the problem of antifungal stewardship. So what is the recent epidemiology, at least in our country? This was the picture which we had shown about 10-15 years back, where we had said that we have got an unique epidemiology of our country, which we have shown that patients who are less morbid, they acquired the infection much early in case of our ICU. So that is very important. You know, if you see in the Western world, the usual average period after the ICU admission, acquiring candidiasis is around 23 days. But what we have shown in our country that within 8 to 9 days they acquired the infection. So our intervention strategy would be different. Next important thing what we have shown is that antifungal resistance coming up, and now what we are seeing that even in case of Candida parapsilosis and Candida tropicalis where the resistance is coming up. This was a pie chart where it had shown that the 31 species of Candida which were producing the infection in case of our bloodstream. And here what is most common was the Candida tropicalis, then it was Candida albicans. And very recently one study had been conducted, that is again multi-center, 15 ICU, where it had been looked into. What it had seen that the major change is that if you see earlier it was Candida tropicalis, then it is Candida albicans, but now after Candida tropicalis it had become Candida auris. So that's a major important factor. So what is this Candida auris? Whenever people ask me, I say it's like a bacteria. You know, in case of fungi, we used to know that the resistance grows very slowly by process of mutation because there is no beta-lactamase, there is nothing called jumping gene, there is no transposon, nothing was there. But this particular bug is developing resistance so fast. So it's one of the important fungus which is just behaving like bacteria. It contaminates the environment very quickly and it transmits very fast, one patient to another patient very fast. And we have seen in our hospital that in a trauma ICU, after entering one patient with colonization, within 4 days, all the patients got colonized. So this is a very important challenge and difficult to identify by phenotypic method and difficult to manage this particular group. It was in 2008 first in Japan and South Korea where it was first being seen, and within a year it came in India, and now as I mentioned it is in 80 countries in the world which is being there. Again, I am saying you this is the first study which we have done 10-15 years back where we have shown Candida auris is the 6th rank in order. But now if you see even in case of Parishit's ICU, this has been shown to be the first rank in order in bloodstream infection. Also in case of Delhi ICU, it is the first rank in order in bloodstream infection. And another study which we have conducted in 2024, that is 67 Indian ICU, where we tried to look into epilepsy infection, we found that the Candida auris is the first rank in order. So I'm saying you, I am not very sure what is the scenario in Kerala. I tried to look into your publication. I could not see anything which had come out from Kerala ICU about Candida auris, but I am sure it is being persisting here. You need to take care of it. Now, in case of Candida auris, we have come to know that there are by genetically divided into 6 clades, and the clade which we are seeing in our Asian countries, especially in our South Asia, in India, Pakistan, all these are clade 1. And if you see, clade 1 has got the highest resistance. Look at this, fluconazole resistance is 94%. Ambisome also there is resistance up to 46%. Even caspofungin resistance is coming up around 22.6%, which have been there. So we need to identify this Candida auris quickly. Now, if I have to say that a lot of people ask me, can I prevent the entry of the Candida auris in my ICU? First thing is that you have to identify any patient who is coming to your ICU as a colonized with Candida auris or not. Here, if you do the phenotypic method, it's not helping in identification. So What can help in this issue is that either you have to have MALDI or you have to do the sequencing which is there. But you will say that we don't have MALDI and we don't have sequencing, what to do about it? In that scenario, we try to develop a phenotypic identification method, a selective media which we have developed with enrichment with salt and ferrous sulfate, and it could specifically identify Candida auris. But it is taking 48 to 72 hours. That doesn't help in your ICU to prevent in that sense. It is taking so much. You cannot keep a patient away from your ICU that period of time. So there is another method came up. It is the chrome agar method that can at least quicker than this procedure, but it is again taking 24 to 48 hours. But luckily this kits which had come up, that is the PCR kit, that can identify within 1 to 1.5 hours. So it is Candida auris usually colonizes your axilla, groin, and usually the near. So if you can have a swab and can collect the sample before a patient who has just entered in your ICU or when it had come, just collect within 1 to 1.5 hours, you can say whether the patient is colonized with Candida auris or not. So this is a major challenge has developed, and here infection control strategy is very important in case of Candida auris, where you need to look into the contact precaution, dedicated equipment. You have to, if there is colonization, you have to do the decontamination. All these factors need to be looked into as an infection control strategy. Now, life is not so easy. Everything is getting complicated day by day. Here, if you see, we were handling Candida auris. Now, what it has been seen that in the Candida hemolini complex, there are other species which are coming up, which are also getting spreading across the Asian country. Like these particular two bugs, Candida vulturana and Candida khanvi. Luckily, these two are not in India till now. Candida vulturana is seen in case of Malaysia and Philippines, and Candida khanvi is in the Middle East. But they are also resistant, just behaving like Candida auris. But what we have is the Candida blanchi. Candida blanchi, first outbreak which had shown in Delhi ICU, now it has been seen in multiple other centers in case of our country. This is again behaving just like Candida auris, adhering to the plastic, biofilm formation, tolerate high temperature and salt. So, friend, we need good microbiology laboratory so that we can quickly identify this species. Several times you have seen in IDSA guidelines, it has been clearly mentioned that whenever you have got yeast in blood, you have to start with echinocandida. But when we did a study across multiple Asian countries, we also participated in that study. We found around 8% of the blood isolate of yeast is not Candida. Something else which have been there, and those species which have been shown to be resistant to echinocandin. Here they are sensitive to liposomal amphotericin B. So friends, it's not that the yeast you start echinocandin, you start identifying the yeast. That is very important in this scenario. So what are the current challenges? Of course, we have got at least some knowledge in epidemiology. We know non-albicans Candida species has emerged. We know Candida auris is there. We know antifungal resistance is coming up. But regarding diagnosis, still in case of the blood culture, we are facing the challenge that around 50% cases we fail to diagnose or fail to isolate it. And Candida, in case of intra-abdominal candidiasis, major challenge is that only blood culture positivity is around 15%. So that's a big problem. So you need a surgical sample in intra-abdominal candida infection. And biomarkers not well standardized. And if you see, because of all this, we have misuse of antifungal. This is in case of prophylaxis, this is in case of empirical issue, and we need and PKPD factors which is being important. And already I have mentioned that though we have an overall improvement in health system and ICU care, mortality in case of invasive candidiasis is not going down. So our major challenge remains in case of diagnosis and treatment. So let's next go. Can we improve the diagnosis? Anything which can we do? Coming to the blood culture, it is in case of the autopsy comparison wise, you have seen that the sensitivity varies in different studies from 21 to 71%. But what you can do is that if you do a large volume blood culture, you can improve the sensitivity up to 70%. But again, the turnaround time is still 2 to 3 days in case of the blood culture to become positive. So 2 to 3 days in a patient when if you have got invasive candidiasis maybe a bit long, because it has shown by hours if you delay the therapy, mortality increases. So there is one technique had come up. This is called T2 magnetic resonance imaging technique, and this particular technique can identify the presence of candida within 4 hours. But major problem is that it can only identify 5 candida species. As I have mentioned that we have got around 31 candida species. And do you know the cost of this test per test was $300. $300 now, $1 is 100 rupees. So 300 means 30,000 rupees per test. Is it possible for our country to do all these aspects? So what already been mentioned, especially that is in Maldi, that is one of the way we can quickly identify. You can see compared to even DNA sequencing, it can identify much early. These are the chrome agars which are coming up as a really quick identification wise, which can help in case of identification. But despite all these things, when a real patient comes in case of this, in your ICU, you start thinking whether it is bacterial sepsis, whether it is fungal sepsis. If the culture is positive, that is at least helping. But if the culture is negative, then the problem comes is that you have inaccurate diagnosis resulting in inappropriate therapy. That's why we made a very provocative statement few years back. We mentioned that delivering antimicrobial resistance agenda will not be possible without improving fungal diagnostic technique. That means if you have to have even antibacterial stewardship program, you need to improve in case of this antifungal stewardship. Now, I know this is, you cannot see from the back so detailed, but this is the guideline which had come up in that is the world guideline in case of the candida infection. There is nothing which is being new which have been provided. It is said the same blood culture had to be done and sampling had to be done in a large volume culture which have been, and ultimately doing the susceptibility. They had said that the moderate recommendation regarding the biomarker test which have been there. But I would say this biomarker test is useful at least in case of it has got a good negative predictive value. Suppose if you have started antifungal thinking it's an invasive candidiasis and beta-D-glucan is coming negative, at least you can stop the therapy. That is very important issue which can be done. And even in case of this global guideline, it has mentioned as a B means moderate recommendation which have been given in case of discontinuation of this therapy. But in case of this ICU, while doing beta-D-glucan, few things you must remember that it can give false positivity in severe sepsis, liver disease, hemodialysis. Even contact with a fiber of a gulch can give you a false positive result. Whenever you are collecting the sample, if you are rubbing very hard, there is a possibility of giving false positive in beta-D-glucan. So you should be careful in this regard. And false negativity has been seen in case of Candida auris and Candida parapsilosis where it can be there. So what about intra-abdominal candidiasis? Can it be helpful by doing the peritoneal fluid beta-D-glucan? This has shown that at least peritoneal beta-D-glucan has got a very good negative predictive value. And there is a study which has shown that combining this serum and peritoneal beta-D-glucan can improve the diagnosis in case of invasive in the intra-abdominal candidiasis. So that is one of the major breakthrough. I would say major breakthrough because a lot of times we are not able to diagnose these cases. Now, a lot of people say procalcitonin. Procalcitonin, which is raised in case of bacterial infection, though Dr. Rajiv Suman just mentioned the problem of procal. But I would say that in case of the virus and in case of fungus, generally procal does not go up. So people used to think, can we use procal as a at least marker, thinking that whether it is bacterial sepsis or fungal sepsis.
There is a Cochrane analysis which showed that procalcitonin standalone cannot differentiate candemia from bacteria with confidence. So here what they are mentioning, or what it has been found, that if you combine with beta-D-glucan, then you can increase the positive predictive value, as well as negative predictive value can reach up to 100%. So it is combining both the tests can only help in this scenario. What about Candida PCR? There are several studies which have been conducted, but somehow it's still not been standardized and validated. You know, it has not shown any improvement in case of sensitivity or specificity, though there is a real improvement has happened in case of Aspergillus PCR, but it is not in case of Candida PCR. So then the people started thinking, can we do in peritoneal fluid the PCR? Because that would be very important. Yes, it can be used, but it can be adjunct to existing diagnostic tool. You cannot say that this is the only way you can diagnose these cases. So if I have to sum up the scenario of the diagnosis, I would say that the blood culture is the gold standard. You need species identification. You have to see large volume blood culture. That is very important. Beta-D-glucan, yes, it helps in case of the negative predictive value, where it can stop empiric therapy. Menon and antimenon, this is the test not so much commonly used in case of India. It has been used more in case of the European people, but this is not giving any additional benefit. Moreover, if it is a non-albicans Candida species, menon antimenon is not that sensitive. Next, T2 Candida, I have mentioned that this really good in case of the turnaround time. Within 4 hours you can get it, but it takes a lot of, it's a cost-wise very important, and it is really only 5 Candida species can be identified. PCR and Malditop already I have mentioned. So there is a problem. So Dr. Rajiv Suman, Dr. Atul Patel, and Dr. Suhas Todi and myself were thinking what to do. So we tried to develop a protocol. We tried to say that if beta-D-glucan is not available, start empiric therapy, but re-evaluate the patient after 72 hours. If no clinical improvement, think of alternative diagnosis. And if there is improvement, continue the therapy. So that is the only solution which we could give, nothing more than that. So here what is happening ultimately, we are happening, that is the empiric therapy is that rule of the day, and that is happening because when you show this chart to a clinician, if you delay the therapy, your mortality increases by hours. You always go and start giving therapy before going to sleep in case of this Candida. But the problem is here. You see that when we have looked into what is the inappropriate therapy, 30 to 50% in best of the centers it had been there. And you know the cost of the drug is so high in number. And there is toxicity issue, so much of these factors. And when we did this particular systematic analysis of diagnostic stewardship, we showed that it is not only improving in case of your antifungal consumption going down, cost saving, but it is also improving in mortality. At least this, whatever the data available, we did this systematic analysis which showing like this. So there is no escape, but need to do diagnostic stewardship. Now the question comes, when you are thinking of empiric therapy, what is the best drug to be given? You know, this is a chart which is tried to combine IDSA and ECMATE together. You see, in IDSA, they said that if it is any patient giving empiric therapy, thinking of invasive candidiasis, whether it is septic shock or not, you have to give echinocandid. But there is a dichotomy in case of the ECMATE. They said that if there is septic shock, you give echinocandid, but if it is not, then you possibly can give fluconazole. That is very important difference which have been seen. And after, if you see targeted therapy wise, again, if you have got a patient where there is a suspected echinocandin resistance and multi-organ failure is there, then you go for liposomal amphotericin B. If there is no echinocandin resistance suspected, then you can give echinocandin. and the opposite in case when you are giving fluconazole. So here, if there is clinical improvement, you can de-escalate, and if there is no, you continue with the therapy or think for the alternative diagnosis in this scenario. But again, I am trying to bring this fact. Can we use fluconazole when at least the ECMID had mentioned, though IDSA said no, you have to give echinocandide. This is a very important study where it had shown that fluconazole used in the treatment of candidemia caused by susceptible common candida species may not be associated with higher mortality. So you can possibly give fluconazole in that scenario. That is very important. And even in case of step down therapy, at least fluconazole can be given. That is very clearly being mentioned. So now let's approach a patient so that how we can help in this scenario. This is a 50-year-old female, ileal perforation, semi-conscious, vital stable, was admitted in ICU. She was in respiratory failure and she is known diabetic hypertensive for 9 years. Apache score was 23. She was intubated, central venous catheter inserted, TPN started, and this patient was put on piperacin tazobactam combination. Vital stabilized on 7 days, so 10-day ileal leak was repaired, and peritoneal wash fluid was sent to lab, but it was shown to be sterile. But third day post surgery, she had fever. Blood culture, blood pressure showed that it had gone down. Leukocytosis is there, D-dimer positive. Blood culture and drain fluid still sterile. CRP 75, Procal 1. And this patient ultimately, because of having fever, antibiotic was changed to meropenem. Now the question is, do you think this patient have invasive candidiasis? Can we predict fungal infection in this patient? What are the risk factors for invasive candidiasis? What are the investigations to be sent, culture based or non-culture based? Do you think this patient need antifungal prophylaxis? At least regarding antifungal prophylaxis, any cohort, at least it should have more than 10%, which have been shown that if there is repeated perforation which have been there, intra-abdominal abscess, secondary or tertiary peritonitis, you can think about giving prophylaxis. But at least in this patient, no prophylaxis had been given. Now, people try to go with the risk factor. What are the risk factors which have been shown in this is case control basis? This risk factor had been identified, and this is the odds ratio had been shown. And here, if you see in this patient, patient was on mechanical ventilation, diabetes was there, total parenteral nutrition was there, abdominal surgery was there, patient had got the broad spectrum antibiotic, ICU stay, already long stay which have been there, and patient was on central venous catheter. So in this particular patient, if you have to go with a so-called predictive rule wise, there are 3 rules which have been shown to be very importantly being used: colonization index, candida score, or predictive rule. All these rules have shown that false positivity is too high. Here it is very difficult to diagnose by this. Yes, negative predictive value is good. Positive predictive value is not being utilized so much. And there is a very important study which have been conducted in case of your, especially in India, from this SGPGI in their ICU. What it has shown, our patient has got very high candida colonization rate. You see 95% colonization rate. If such a high colonization, that means every patient would be given empiric therapy. That is not been possible in that scenario to be done. So what we can do in this scenario, this course should be used for problem focusing sampling for diagnosis, not helping in case of starting the therapy that is being there. Now in this patient, because of these conditions, as I have said that there are so many risk factors, so this patient had been given empiric antifungal, that is anidulafungin 200 milligram day 1 and 100 milligram day 2 onwards. It's been given to this particular patient. 5th day post surgery, fever still persisting, galactomannan is 0.7, beta-D glucan 60 picogram, not very clear whether it is high or low. Sputum confluent candida tropicalis, urine culture showing candida glabrata. Now clinicians started asking what should be done. Is it that at least urine culture showing more than 10,000? First thing is that nothing like bacteriuria, there is nothing called candidiuria in particular count wise. So there is nothing you should not do count in case of the candida, that is very clear, which have been recommended. If you see IDSA guideline, candida from respiratory secretion usually indicates colonization, and candida in urine treatment with antifungal treatment is not recommended until unless the patient is neutropenic or the patient is having high risk because of manipulation or patient is of premature baby which have been there. So there is no significance of counting candida in the respiratory tract or urine which have been there. So in this particular patient, luckily at least the blood culture came positive on day 7 and it grew east. So the question again I have mentioned to you that whether the species identification is necessary or not. Yes, species identification is necessary because you can see, yes, preferable echinocandin is the first line of therapy, but in case of Candida auris, you see that we need the susceptibility dependent, because there are several patients which have been seen nowadays that we do see that it is echinocandin resistant. So in this, species identification would be important, and here the patient's species came out to be Candida parapsilosis. And if you see MIC with anidula was 1, mica 0.25, flu 1, vori 0.5, amphotericin 0.25. Now here the thing is that at least the breakpoint wise, if you see in case of the CLSI or UCAS, patient was giving anidulafungin. So it's a sensitive position, isn't it? But again, I am now coming into the issue that the patient have got the problem in case of the in the peritoneum, that is intra-abdominal candidiasis or not, which have been there. Therapy wise, yes, which have been recommended is the same thing, that either the echinocandin as the first line of therapy, or you have to give the rezafungin, which is the new drug, as I have mentioned, echinocandin, which have been there. Now, in this patient, day 11 post-surgery, fever still persisting, and leukocyte count has gone up to 18,000, and now beta-D-glucan has crossed 500. So, shall we modify the antifungal which have been given anidulafungin in this? Now, if you see in case of the healthy volunteers versus critically ill patient, the PK in case of the anidulafungin varies. You see that in case of the critically ill patient, it is AUC-MIC ratio is going down, and here echinocandin is highly protein bound. Unbound function only passively diffuses in the extravascular space and penetrates the peritoneal fluid. So you see that the peritoneal fluid versus in serum, that is, if you see that the Cmax is much lower in peritoneal fluid, as well as the AUC which have been there in this particular patient. So here, treating drugs should attain adequate concentration at the site of infection. Moreover, if we have to look into the PKPD issue in case of the patient is critically ill, you have to think about, already a lot of discussion had been there in case of bacterial situation, antibacterial drugs. But in case of antifungal, especially in critically ill, if there is volume distribution issue comes when the patient is giving hydrophilic drug like echinocandin or fluconazole, of course, now we have ECMO issue is becoming very important. ECMO squeeze out echinocandin, that is very important issue which have been done, or which have been seen in that. And PD also become a problem, impaired tissue penetration, biofilm and indwelling surgical dent. And here, as you have seen, that particular patient, when it is not penetrating well, in case of peritoneal fluid, and the patient is not improving, so in this patient, we started thinking what to do. And if you look into this global guideline in intra-abdominal candidiasis, only the green portion has been seen in case of liposomal amphotericin B at the last portion, which you can see. So here, ultimately, patient had been given liposomal amphotericin B, and then the patient responded after day 13 onwards. So you see that it is very important in case of your intra-abdominal candidiasis, what drug to be given, how to be given, when to be given, what are the factors to be looked into. Now, there is this particular study I am very getting more interested. You see, in this particular patient, where it had been shown single dose high amphotericin B which have been given. And then on day 3 onwards, this has been found that the liposomal amphotericin B discontinued and BRG become negative. Otherwise, if it is not negative, BRG continuing these drugs which have been there. So again, the single dose therapy concept is coming in this scenario, but I have no idea about it. I have not used in this. So this is one paper which I thought bit excited to look into this issue in this way. Shall we take out the central line in this patient when candemia is detected? Usually, IDSA guideline says central line to be taken out. But my friend Marcio Nucci, he came out with a great idea, and he showed that in case of your, especially in case of your ICU patient, there is no difference whether you take out the central line or not. But MDs and other people, they had showed no, central line should be taken out. So what I feel is that without any randomized trial of early CVC removal versus retention, better to remove CVC when possible. Otherwise, give biofilm active drug like echinocandin or polyene, because azole would not be effective in case of biofilm. So this is the only solution which we can do regarding this. Next question is that if you have got a candemia, do you need to check every day retina or eye examination? There were earlier recommendation was that after a week you have to do routinely this test, and this is very important. But what it is now being seen is that we are wasting our manpower. First thing is that it is not so easily being available, that ophthalmologist, at least clinician, had to use the ophthalmoscope well. Otherwise, there is a problem which have been there. So here, ultimate recommendation is that may perform after 1 week. Those with ocular symptoms or signs, is not that all patients should be done. If there is symptoms of signs, immunocompromised patient and persistent candemia where need to be done, and those who are not able to verbalize the complaint, possibly, especially in case of ICU, need to be done in that scenario. So ocular candidiasis, if it is there, what drug to be given? Echinocandin don't penetrate. And there you have to go either for liposomal amphotericin B or voriconazole or fluconazole. You cannot continue with this drug. Now the question comes about the duration of therapy. The standard protocol, people say once blood culture becomes negative, you give it for 2 weeks. That is the standard which have been recommended. But where from this has come is not very clear, especially this particular study. Now there is a study going on across Europe in multi-center, which is going to be published very soon. It has shown that there is no need of this 14 days, possibly in lower period, because if you see that the short course versus prolonged period, there is no difference in case of mortality as well as the candemia recurrence. So this is very important issue which need to be taken care of. If there is persistent candemia, you are not able to handle, these are the point you must first look into. One is the source control. If you are not able to do the peritoneal toileting well, you will not able to succeed in this scenario. Next is about the antifungal therapy, whether it is penetrating well or not, that should be there. Microbial monitoring should be important, and resistant testing. So these are the factors which need to be looked into. People ask me that can we give combination therapy when the people are not responding to the therapy? I would say that the combination should not be default approach. It should be targeted intervention. What you are trying to achieve, this aspect need to be looked into. So here, scenarios where it may be justified, like endocarditis, obstructed renal candidiasis, ocular or CNS involvement, persistent high fungal burden, or ongoing candemia despite source control, antifungal resistance, and PK uncertain due to ECMO or CRT, obesity, DDM. In this scenario, you can think about combination. And combination can be the azole plus liposomal amphotericin B, echinocandin plus azole, or liposomal amphotericin B with 5-fluorocytosine can be done. and reassessment need to be done 48 to 72 hours so that you can come down to one therapy instead of continuing with the combination therapy. So de-escalation to the narrowest effective monotherapy after source control and identification is most important. Lastly, though, I am going to discuss this newer antifungal as a separate presentation on the last day. But what I am trying to say is that now at least certain drugs which have come up, and if you look into this, especially in case of the invasive candidiasis, azole-resistant candida situation, you have now newer options coming up like rezafungin, ibexifungerp, and phosphomanogepix. In case of the early discharge, if you have to do specially giving the oral drug, we have the ibexifungerp, that is very important, or phosphomanogepix, or rezafungin, which is given once in a week, can be given in a day care basis. It's not necessary you have to keep the patient always there. And in case of the if there is interaction, drug interaction or hepatotoxicity, at least you see these are the drugs like ibexifungerp, rezafungin, phosphomanogepix is good. Orofim is not being used against candida, so be careful. Orofim does not work against candida. You must know about this aspect. In invasive candidiasis caused by echinocandin-resistant candida species, where you can use ibexifungerp, phosphomanogepix. That is very important. In case of the complicated issue, complicated candidiasis requiring prolonged and simplified intravenous therapy, rezafungin or ibexifungerp is important. And in case of the lipid amphotericin with nephrotoxicity, if it is there, then you can go for phosphomanogepix, which have been there. So summarizing what I tried to tell you is that several loose events in defining the standard care of ICU. Diagnosis is important. You need to have a faster rule in or rule out bundles. That is very important. And here large volume blood culture would be useful. Serum and compartmental BDG we need can be done, as I've mentioned that in case of your peritoneal fluid BDG, combining with serum BDG can help in case of invasive candidiasis of the abdominal area. We need point of care test. Somehow it's not being still developed in case of invasive candidiasis. Rapid species identification is very important. Next gen sequencing for resistant marker important. Electronic health record risk scores that trigger start, stop, and switch decision of antifungal can be thought about. That is, I have no planning exactly to give you, but certain centers are doing this, using this risk factor analysis to start, stop, and switch drugs which have been there. Candida auris screening is important in those ICU where Candida auris spread is noted. Treatment-wise, exposure, optimization, bedside sampling, early TDM, precision dosing, that accounts into ECMO and obesity should be taken care. Next, echinocandin have several issues for treating invasive intra-abdominal candidiasis, which I have mentioned, where liposomal amphotericin B may be considered, or combination therapy for short duration. New antifungal which have shown that more experience is required. So friends, this is one course which is there online in Fungal Infection Study Forum website. You can go through this course. There are 16 module lectures are available, and this is completely free of cost. And at the end of this course, you can go through a test. If you qualify for this test, this is an online test. You get the certificate from Fungal Infection Study Forum going through this particular course. This is a very important course. You know that it would help you as a module wise learning about all the fungal disease, which is important in case of your ICU. Thank you for your kind attention.
Thank you very much, sir, for that highly informative and thought-provoking plenary session. As this was a plenary lecture, we will not be having a Q&A session. May I now request the audience to kindly rise and join me in giving sir a warm standing ovation.
Any question, I am not asking for this standing ovation. I am asking for question if it is there. I know this is its problem. This is its problem area. Any question you have got? So, plenary lecture, you can ask question, that's not there. Anything which is a problem for you people? How much is the Candida auris in case of your Kerala? Anyone has studied this? Because I could not see any data. Are you identifying? You have Maldi. If you don't have Maldi, how you are identifying? By? Vitek will not able to identify Candida auris. But what you can think about, if something which is showing fluconazole resistant, if something which is not able to grow, which can grow at higher temperature, think can it be Candida auris? If Vitek is giving you bizarre identification, like Candida sec, Candida humuli, something different, then you can think about Candida auris or not. Vitek will not have diagnosed Candida auris. So nobody has seen any Candida auris from Kerala. Either you are doing very good, which Parikshit is doing very bad. That's huh? No, that is okay, but the thing is that you have to find some solution. You know, the thing is that Candida auris is such a difficult organism to manage. Your patient will be dying, you will not know about it. So you have to have something or process for identifying Candida auris. We have a selective media developed, but it takes almost 48 hours. This can be used in your lab. This is being used in many centers now. But the thing is that at least you have to use Candida auris is a very important issue. So only one multi. No, but the thing is that multi is, it might be expensive for purchasing one equipment. It's 1 crore rupees one equipment, but consumable cost is nil. Consumable cost is so less. It is like 10 rupees. No, and another thing can be done is that, like, suppose each city can have one multi, and it's one center requires only for half an hour to 1 hour for the multi for identification. So other centers can pool their samples and can do this. At least you should have multi. Gita, you have got multi, na? No multi? Rajiv? So you send a sample. Then it's okay. Then it's okay. That's why I'm saying you can do it and sending the sample to the other places. So daily it goes to your place. Good. That is. So अरे भाई इतना बैक्टीरिया आइडेंटिफाई कर देते हैं विदिन मिनट. ठीक है, but I am saying those who don't have, like Kerala don't have multi. Kerala health system is so strong, and I feel that there should be multi here. Jacob, at least convince your bosses that you should have multi, and then you whole Kottayam area surrounding can come here and do. You can charge and you can earn. It had been shown that if you purchase multi, within 3 years you can raise the cost. Within 3 years, it had shown very clearly. If you use optimally, within 3 years you can. It's not fungus, bacteria. So quick identification you can give within few minutes, and possibly we are going to do the susceptibility with multi, whether it is bacteria or fungus. we are going to do the susceptibility very soon. It's in the process of standardization. So that can give you a result very quickly about susceptibility. So what about intra-abdominal candidiasis? Joseph wanted to hear. You don't see or you don't diagnose? Diagnosis. That's an important issue, because a lot of patient multiple perforation. Another thing is that we cannot go same guideline as the Western world. The reason I am saying you, suppose in Western world they say that whenever there is a single perforation, usually there is no intra-abdominal candidiasis because they immediately do this surgery. But here, one patient who have got an abdominal perforation, he is being operated after 48 to 72 hours because he is coming from village, diagnosed, and ultimately going for this. By that time, candida can settle, and that may produce intra-abdominal candidiasis. So that's very important issue also. So we cannot say the same guideline as in case of the Western world. They say first perforation there is nothing that is intra-abdominal candidiasis, but it can happen in India. I'm saying this is one of the important factor we need to take care. Okay, I think I saved some time.
Before we pause for lunch, I request all the participants of podium presentation to kindly submit your PPTs at the designated desk located inside the hall on the front left side. Participants of the podium presentation are requested to have their lunch first and rejoin the hall at the earliest, as the session will commence at 1:35 p.m. sharp. Lunch has been arranged on the right side of the hall. I request everyone to kindly join the same and return by 1:35. Also note, food and beverages are not permitted inside the hall, and the washrooms are located on the left side of the hall. Thank you and enjoy the meal.